We begin today's session with Professor Hitharjus Aki's lecture. Yesterday we have heard him about small fiber neuropathy. Today he will be delivering his lecture on central post-stroke pain, clinical characteristics and management. We welcome Professor Aki.
Both of these on? Good, great. Okay, good morning everybody. Nice to see you that all of you, most of all of you are here around. So this morning first talk will be about central post-stroke pain, about the clinical characteristics and management. So what I'm going to talk here this morning is I first go through the definitions, what is meaning here. And then about the epidemiology, diagnostic criteria of post-stroke pain, and also some about the clinical characteristics and prognosis of this condition. And also something if we can predict when we see these patients in emergency room or during the first days of stroke, what are the predictors by which we can assume whether this patient is developing post-stroke pain or not. And last, I talk something about the management issues. So, what is central neuropathic pain? First, I'm going to give you the definition of central neuropathic pain. And here is the definition by ISP, International Association for the Study of Pain. So, this is a pain caused by a lesion or disease of the central somatosensory nervous system. And then if we go to the different conditions of central neuropathic pain, so central post-stroke pain is just one of these conditions where we can talk about central neuropathic pain. The other major conditions include, for example, pain associated with spinal cord injury, which is quite common. So I would say about 75% of patients with spinal cord injury develop quite severe central pain. And then in our country and Scandinavian countries, multiple sclerosis is a very common disease, neurological disease. Central pain associated with this condition is also one of these major conditions causing central neuropathic pain. And then there are some other conditions like brain lesions associated with tumor or trauma. Parkinson's disease patients may suffer from central pain, and patients with syringomyelia, and also some CNS infections, mainly abscesses and encephalitis are also related with central neuropathic pain if these patients survive their disease. And then, if we think about post-stroke pain, then we have also some other diagnosis than central post-stroke pain. So central post-stroke pain is one very important reason for post-stroke pain, but there are also others, as you know. We have to make a difference between central post-stroke pain and these other conditions, including spasticity-related pain, musculoskeletal pain, which is very common, including mainly glenohumeral subluxation and contractures. And then some patients may also develop complex regional pain syndrome, CRPS. When I started to come into pain medicine about 20 years ago, then this was a very hot topic issue. There was a debating and arguments whether patients with stroke can develop CRPS or not. So there were some eminent speakers and researchers against this idea, but more and more information came about this topic also, and now majority of authorities believe that yes, stroke patients can also develop CRPS, but this is not central syndrome. And then also post-stroke headache is one of these conditions which some of these patients may develop. What about the epidemiology of central post-stroke pain? The prevalence is variable, so it varies between 1% and 12%. But if we think about some issues here, it seems to be that the first studies, I think, remember they were made in Denmark. So they were showing that the development of central post-stroke pain seems to be associated with sensory impairment. So if we have stroke patients who have a sensory impairment, the major symptom, the prevalence in these patients is 18%. Compared to those patients with all patients with stroke, where it's about 8% the medium. So if we have, for example, patients with severe sensory impairment in stroke in the initial phase, then the risk to develop CPS, central post-stroke pain, is much more higher than stroke patients in general. And then very nice study was made in Finland a couple of years ago about the prevalence of young ischemic stroke survivors, so patients younger than 55 years. So in this group of patients, the prevalence of post-stroke pain, central post-stroke pain, was 5.9%. Here is the abstract of this study. So there were altogether 824 patients, and of these patients, 49 had developed central post-stroke pain, so it makes 1.9% of these patients. And this study also showed what is the risk period of developing post-stroke pain, and this diagram shows the data. But find out that this is the number of patients included here, not the percentage. So of these 49 patients which had this central post-stroke pain, about 13 patients developed the post-stroke pain within the first 7 days, so within 1 week. And the majority of the patients, it was 26 patients, developed this central post-stroke pain within the first month, so more than 7 days but less than 1 month, so within the 3 weeks after the first week. And then there were 8 patients who developed the central post-stroke pain within the 6 months, first 6 months after the stroke. So this is how it goes in most patients. So if we think about the epidemiology once more and the location of the stroke, so actually you may develop this post-stroke pain no matter where the lesion is. So at any level of the somatosensory pathways in brain, whether is it in medulla, whether is it in cerebral cortex or in thalamus. But the prevalence is dependent on the location of the lesion. So there are some locations where the risk of developing post-stroke pain is much higher than in some other locations. And it seems to be, according to the studies, highest if the patient has stroke in lateral medullary area, or also the lesions which are located in the ventroposterior part of the thalamus are also in risk of developing post-stroke pain. These are the highest risk areas as to the location. So here in this diagram, there is the percentage of these different post-stroke pain conditions. And if we look about this diagram, it shows that the musculoskeletal pain is much more prevalent than central post-stroke pain, but as you can see, there are also overlapping areas. So in general, 40% of stroke patients, post-stroke patients who are complaining of pain, they have some kind of musculoskeletal cause behind their pain. And this central post-stroke pain takes about 10% of this whole pain condition in post-stroke patients. Also, post-stroke headache is about 10%. And this, if we think about this musculoskeletal pain in general, within this group, painful spasticity is about 7%, and shoulder pain is 20%. So all these patients who have this developing very severe motor paralysis, they are prone to develop this subluxation, but that's not central post-stroke pain, that is nociceptive pain. And that's quite common also. So, what about the diagnostic criteria for central post-stroke pain? Actually, very recently, 2 different diagnostic criteria have been published. This was the first one in 2009. This was according to a Danish review, which was published in Lancet Neurology in 2009. And I will show you also the most recent one, suggestion for central post-stroke pain, but let's go first this one. So the mandatory criteria for the diagnosis of central post-stroke pain include first, that the pain has to be neuroanatomically logical. So it has to be, the pain location has to be within an area of the body which corresponds to the lesion of the central nervous system where the stroke is located. It has to be neuroanatomically logical. And then the history of the patient has to suggest a stroke, and onset of pain has to be after stroke onset, not before, of course. And then we have to confirm that there has been a central nervous system lesion by imaging, or if there are negative or positive sensory signs which are confined to the area of the body which corresponds to the lesion. And then we have to exclude other possible causes such as nociceptive pain or peripheral neuropathic pain. So these are the mandatory criteria by which we can diagnose central post-stroke pain. And then there are some supportive criteria also. So there should be no primary relation to movement, inflammation, or other local tissue damage. So nociceptive pain should be excluded. And then most patients are describing their pain as burning, painful cold, electric shock-like pain, aching pain, pressing pain, stinging, pins and needles, but all pain descriptors can apply. So these adjectives these patients are using, it depends on the culture and language and many things, but most pain descriptors apply here. And also, if you find in neurological examination allodynia or dysesthesia to touch or cold, so thermal allodynia, that's also very important sign of central pain. So this is the recent diagnostic criteria, which was also, there were quite many of these authors were from Denmark, also some from USA. So this was a combined working group of American Pain Society and Research, Education, Treatment and Advocacy Institution. And they just published it in December last month in the Journal of Pain. So these are the suggested new criteria for chronic central post-stroke pain. It's almost the same as this published 8 years ago, but there are some aspects which are now more clearly made in this new criteria. So we have to confirm a stroke by the diagnostic test or a history which is strongly suggestive of stroke. So that's number one. And then there has to be, the pain has to be either continuing, ongoing, or recurrent after a stroke. And they have now defined how long it can be after stroke, and this is very important. I think if we think about whether the pain can be post-stroke associated or not. So the onset of pain can be start at the time of stroke or even up to 1 year after stroke onset. So in some patients the central post-stroke pain may develop quite late, but maximum 1 year after stroke onset. If it develops after 1 year, then it's quite dubious whether it's related with stroke or not. So that's why the timeline is cut here in 1 year after the stroke onset. And pain duration has to be at least 3 months. Otherwise, the criteria are about the same as I was talking about. They have also given more definitions about how this pain is associated with sensory changes. So there has to be at least one positive sensory sign, for example, dynamic, mechanical, or cold allodynia, or at least one negative sensory sign, for example, elevated thresholds to cold or warm sensations, or decreased sensation to touch, pinprick, or thermal stimuli, which are very clear indicators of central pain. So what about these clinical characteristics and prognosis of central post-stroke pain? It seems to be long-lasting and even lifelong. So in some patients, and in quite many patients, I have to admit, the prognosis is not so good because it may be lifelong pain, which they will suffer. But in some patients, we have found out it may diminish within the years or even disappear over time. So in some patients are lucky enough that the pain will go away within the following years. But we don't know why and not yet know what are the predictors of these conditions in patients in whom the pain will just subside. We know that some patients, when they develop a subsequent stroke, it may exacerbate the previous condition, but in some patients, I have also had that kind of patients, the patients who developed another stroke, he was lucky enough so that this new stroke developed in that kind of area that it inhibited the previous stroke pain, and he was totally pain-free after the second stroke. So this may happen also. The pain may be spontaneous, so that it means ongoing pain, or it may be evoked. So all these patients who complain that they are not able to sleep because the bed sheets are, they are not able to tolerate the bed sheets. This is an example of evoked pain, so that some external stimuli are causing the pain. It may be ongoing or it may be intermittent, and also the intensity of pain fluctuates. So in some patients, stress and cold may increase the pain, and some patients, rest and distraction may alleviate pain. What are the negative signs? I already mentioned about them. So it's usually the loss or reduction of thermal and pinprick sensibility. These are the main components of central pain, so loss or reduction of thermal and pinprick sensibility. They are the negative signs, and then the positive signs that pain or unpleasantness is evoked by touch, pressure, or thermal stimuli. Especially cold is one very well-known trigger of pain in central pain conditions. And then also, if we see this kind of dual combination, so that the patient have, when we do the neurological examination, when they have both loss of sensation and on the other hand hypersensitivity in some areas of the body. So this kind of combination is very suggesting about central post-stroke pain if you see these signs together. The distribution of pain may range from very small area to large areas, so it may be everything possible. But very often, pain is more often localized on the upper extremity than lower extremity. And in some patients with lateral medullary infarction, it's of course always contralateral to the stroke, but some patients with these conditions and very often also may also develop ipsilateral side of the face, of course, depending on the localization. So they have pain on the ipsilateral side of the face and also contralateral to the stroke. And some of these patients may just come because of this ipsilateral facial pain, which may be very severe. And it's one differential diagnosis of unexplained central neuropathic facial pain. So in some patients, the first symptom of stroke may have been so mild that they have never gone to see the doctor in the first place. Some dizziness or some temporary weakness, but if you take the history, you will find out that yes, they had this kind of condition, which was probably when the stroke took place. So, but the only after effect they may be experienced may be this ipsilateral side facial pain. If you think about the quality of pain research, There is one old Swedish study made in 1989. Already then they noticed that it's a great burden for the patients even when the intensity of pain is low. And here you can see some pictures where the pain is located. This is from this Finnish study of young stroke patients. As you can see, there are many different kind of locations for the pain. Some are in lower leg, some in most of patients in upper limb where the pain is located. And here is another study from a Danish pain study also showing these locations of pain in these post-stroke patients. So this is interesting area. Can we predict, if we see our patients who have developed stroke, which patients develop central post-stroke pain and which do not? There is some information coming from recent Danish studies. And I already mentioned to you that it seems to be much more common in patients who have somatosensory deficits. And one important finding in this study was that if within the first 4 days of stroke onset we find that there is evoked dysesthesia or allodynia or hyperalgesia, these three things predict the development of post-stroke pain within the next 6 months after the stroke. So I think it's quite important to study these things if you meet and treat stroke patients during the first month. So if they develop this evoked dysesthesia, so if you do the sensory examination and they are complaining, yes, now this, if you're touching my leg, if you're touching my arm, it feels very painful or it feels unpleasant. So this kind of dynamic allodynia or dynamic dysesthesia or hyperalgesia, all these are predictors of that they may develop post-stroke pain. And also the patient reported evoked pain. If he complains to you that I am not able to sleep here in this hospital bed because I can't tolerate this bed sheets, or my shirt is feeling very painful in my upper arm, or it's very unpleasant feeling. So this may also be a sign if they are complaining it within the first days that this patient may develop severe post-stroke pain. And also the other thing, if there is a combination of early evoked pain or dysesthesia and absent sensation to at least one stimuli at the time of initial examination, then the risk will still increase. If you have this first evoked dysesthesia, allodynia or hyperalgesia, then the odds ratio in this study was 4.6. That was the risk for developing it. But if you have this combination of early evoked pain and dysesthesia and absent sensation to at least one stimuli, then the odds ratio is 13.2. This is the article where I was referring to, published by the Danish people in 2014, and I recommend reading it. It's a very interesting study. And here in this graphic presentation, they show that the frequency of this early evoked dysesthesia is significant in those patients who had developed central post-stroke pain compared to those who did not develop central post-stroke pain. So, last, about the management of central post-stroke pain. First, I have to take that I have to say that this is extremely challenging to treat these patients. Very difficult to treat. And there is only one study. We should do more these studies about this. Is there any help of prophylactic treatment? Because now we know which are the predictors for the patients who develop post-stroke pain. So now we should do more these studies. Is there any help of prophylactic treatment? So far, only one study has been made, and if I right remember, it was in 2002. And they compared amitriptyline with carbamazepine, and they didn't find any effect in thalamic stroke. But the statistical power of that study was not good enough. So there were only 40 patients or something like that, but they didn't find any effect of this prophylactic treatment in thalamic stroke. But no other studies has been made which could be eligible for this kind of analysis. What we have for pharmacotherapy, antidepressants, anticonvulsants, mainly these drugs have been studies, but there are not many good studies. I already now say that you should not recommend opioids for these patients. It has been shown that these mu receptors, which are the receptors of opioids, in post-stroke patients, they seem not to be working at all. So what these patients developed, they developed addiction to opioids, but they will not get any benefit of opioid treatment. So I strongly suggest not prescribing opioids, strong opioids like morphine or OxyContin for these patients. There's been also some intravenous drug trials for these patients, but let's see at what they have been showing. In this review in 2009, there's mentioned some oral and transdermal medications which have been published. Some of them had been positive, some had been negative, but as you can see, the number of patients in these studies has been very low. So it was interesting to find out that this basic study, which is by which the recommendations are based on that the tricyclic antidepressants are effective in central post-stroke pain, there were only 15 patients in that study, 15 patients only. And there's not any other studies on the efficacy of amitriptyline in central post-stroke pain. 15 patients, and the study was made in 1989. There's been some intravenous trials with morphine, lidocaine, propofol, and naloxone. 2 of them were negative and 2 of them were positive, but also in these the number of patients was very low. So not any good quality studies. And quite recently they published this systematic review of randomized control trials in central post-stroke pain. And this is also a very important paper. Actually what they found that there were only 8 studies which were eligible. So only 8 studies on management of central post-stroke pain which were randomized control studies. 4 of them were about anticonvulsants. 1 was on tricyclic medication, 1 with naloxone, 1 with stimulation, and 1 with acupuncture. So here is about these anticonvulsant studies. So only 4 of them. 1 was with pregabalin, 1 with levetiracetam, and 1 with lamotrigine, and not much, only very low or low certainty of evidence in these studies. And this upper panel shows all these 4 studies. So the first one was this Swedish study from 1989, and then there was a study of pregabalin and levetiracetam. Neither of them could bring any good result. There was some efficacy of lamotrigine and carbamazepine, but if we take the total mean difference, it was only minus 0.75, so the difference was not significant. And what was interesting that these guys who made this review, they took again this study where the amitriptyline was showing efficacy, so these 15 patients. When they made the reanalysis of these findings, it was not significant anymore. So actually all these recommendations which have been based on amitriptyline as an effective drug in treatment of neuropathic pain, that was insignificant finding in 15 patients. So we have not much where to base on our treatment. So neuromodulation and other non-pharmacological therapies, these have been tried and studied, but so far not any good information. So what we have to do, we have to use also our other management methods which are non-pharmacological, like psychological treatment, training and in coping strategies and behavioral therapy. And also there's evidence that mirror therapy and virtual reality training may help some patients with central neuropathic pain, but again, no any hard evidence on these either. So what these systematic reviews have taught us, so there's only low or very low certainty evidence of this pharmacotherapy which may help these patients. So anticonvulsants, tricyclic antidepressants, opioid antagonists, and electroacupuncture have no effect on reducing pain associated with central post-stroke pain. This is what we know at the moment, but the studies are of low efficacy, low statistical power. What we have find out that its only positive result was that these anticonvulsants, they may improve sleep in these patients, but that's all. And there was also one study, well-done study about RTMS, but it had no effect on depressive symptoms or patient-reported global improvement in pain in these patients. Last, one case report. There was a 79-year-old Finnish woman who had a history of asthma, polymyalgia rheumatica, hypertension, and hypercholesterolemia. In July 2017, she developed sudden onset numbness and tingling of left hand and foot. And when head MRI was done, there was a right pontine infarction. And within 2 weeks, the patient developed pain syndrome on the left side of her body and extremities. She was complaining that I feel like my body is split in half. She was complaining constant tingling and also paroxysmal squeezing pain of 1 minute duration in arm, thigh, and calf on the left side. And this was her most serious complaining, and the VAS was 8 for this squeezing pain attacks. There was also, she was complaining of unpleasant coldness in hand and foot, stiffness in the lower limb. No spasticity was found out. Well, is this a case of central post-stroke pain or not? What do you think? Yes, definitely so. All the criteria are fulfilled. What medication would you start with in this patient? Yeah, very good suggestions. So what we did here, we started with gabapentin. And dose was increased up to 800 milligrams 3 times per day, but unfortunately no benefit, and she was, for paradoxically, complaining of insomnia. So usually gabapentin helps to improve sleep, but in this patient it was causing insomnia, and she wanted to quit the medication. Then we started amitriptyline 25 milligrams in the evening, and she experienced alleviation of this unpleasant squeezing pain, which was her biggest problem. But she was started to complain dryness of mouth and GI symptoms. So at the moment she's going well with this medication because she finds help of this medication because the squeezing pain has diminished. But we have thought thought that if these side effects will develop more severe, then we probably will try also duloxetine. So we will consider that if the side effects will increase. But at the moment she's quite happy with amitriptyline. Thank you very much.
Thank you, sir, for your nice presentation. Now, gabapentin and pregabalin, if you compare these two, because titration for gabapentin from 100 milligram up to 2000 milligram or that sort of things. So, can we try pregabalin instead of gabapentin? This is one.
Yes, one of these studies, one of these 4 studies with anticonvulsants was made with pregabalin. Actually, they have not made any studies with gabapentin, but it's very common in this pain medicine that we try in all these conditions the same neuropathic pain medications, because the assumption is that all neuropathic pain medications should work in other neuropathic pain conditions as well, because gabapentin and pregabalin have been studies in other central pain conditions and also some peripheral neuropathic pain conditions. So the answer to that question is yes, both of these can be tried. The efficacy is almost similar in these 2 drugs. That's my personal opinion, but the side effect profile may be a little bit different. So I have found some patients, for example, who tolerate better pregabalin than gabapentin, but also vice versa. So you should try both of them. If you think that you first try with pregabalin and you find out the patient is not tolerating that, he may tolerate gabapentin better, but also vice versa. Some patients tolerate gabapentin better than pregabalin. As to the efficacy, it's about the same in these both drugs, so I would mainly go with this side effect profile. But some patients I have had that also experience that if both of these are tried, so they find that the other one is better than the other one. So you better try both of these if the first one is failing, and depending on the availability of these medications. And the maximum dose of gabapentin is actually 2,400 milligrams per day divided in 3 doses. And the smallest dose available in our country is 300 milligrams.
Hello. Thank you very much for a nice review of CPSP. But in this connection, I distinctly remember that a patient presented in my clinic with a extreme coldness, so much so that in hot, humid weather, he has come on with the warm socks on, and that is due. And ultimately found that there was a contralateral, thalamic stroke. That is the history. So you mentioned there's unpleasant coldness but the only coldness with this patient arrived at opportunity. That is.
Yeah, that is true. So that these patients may come to even to your outpatient clinic, so that they don't know whether they have even developed a stroke, but the pain may be their only complaint. That's possible. Yeah.
Sir, what is your experience about DBS for excruciating pain in thalamic syndrome? DBS.
We haven't tried that in our hospital. We have a possibility to do DBS, but so far, as we have looked at the literature, the results of DBS in pain patients seems to be still quite unclear. So thinking about the risks and costs of that treatment, we have still considered that we want to get some more information about the benefits of this treatment before we start. We're doing DBS for Parkinson patients with very good results and epilepsy patients, but treating central pain seems not to be working so well. Not any good studies have been made about this subject so far, so we haven't yet started to do that.
But you told that in one of your patient, another stroke improved the pain. So that tells you there may be a pathway, if interrupted, can improve the pain. So there is a possibility of interrupting the pathway. So studying these types of patient may help you to interrupt what pathway. So there is a pathway which we are not able to block with pharmacology. Definitely. So after all this very nice review, that comment is the best comment, because after the review, as you asked me what is the treatment, I don't know.
That's right. I agree very much. And I think we should do this kind of much more studies about the efficacy of both drug pharmacotherapy and also some interventional studies, but probably we should also combine our forces so that to do international multi-center studies so that we can get high statistical power. So far, not any good studies have been done, but this is very important thing to do in the future somehow.
Thank you, Professor.
Thank you.
For next talk, let me invite Professor Kaul. For this August gathering, he doesn't need any introduction. He is past president of Indian Stroke Association, past president of Indian Academy of Neurology. He has been founder national coordinator of international program BRINB. He is currently professor and head at Nizam's Institute, Hyderabad. As all of us, we know that he's involved in, rather he was pioneer in thrombolytic therapy in India. May I invite Professor Subhash Kaul.
This is the one for... good morning. At the outset, let me thank Lupin Company for organizing this very important update. Let me thank Dr. Patinkar for giving me the opportunity. And let me thank the overseas speakers who have come all the way traveling from abroad. I know how difficult it is to travel, inconvenience and all, and thank you so much so that we don't have to go there. And thanks for all the friends joining here. I'll just give an overview of some of the new things which have happened in the last decade and a half. Everybody knows about the conventional risk factors, hypertension, diabetes, hyperlipidemia, smoking, but air pollution is now a leading stroke risk factor. This is a study which came last year, and it's a global study in which about 188 countries were studied, and air pollution, to which all of us are exposed, especially people from Delhi, is now a leading stroke risk factor. And I want you to read the Lancet Neurology article last year. In fact, it is more in the developing countries like India and China. And in India, it is the household pollution, not only the environmental, but the household pollution, which has been shown to be a stroke risk factor. And it has been seen that it contributes to about 1/3 of the global risk of the study, which means 1/3 of the people who had stroke are exposed to significant higher levels of air pollution. The other risk factors continue to be high blood pressure across all the 3 regions of the world, but low fruit intake and low vegetable intake also is emerging as an important risk factor across the continents. Chronic gum disease is also a risk factor, already well established in cardiology, but many papers to show in stroke also through immunological mechanism, and obstructive sleep apnea is also emerging as an important risk factor by causing hypertension, heart disease, and hypercoagulability. Now, after the prevention, what we have learned is that efficient systems in acute care improve outcome. It has been shown beyond a doubt that responsive stroke teams in a hospital, in stroke-ready hospitals, immediate stroke imaging, and less door-to-needle time substantially improves the outcome. In fact, in Finland, I was just telling sir, in Finland, the door-to-needle time has been reduced to 13 minutes. And this is something which needs to be done in our own country also, and because it is directly related to the stroke outcome. Now, one of the problems with thrombolysis is this tight 3-hour window. But one of the major things which happened in 2008 was this window was extended from 3 to 4.5 hours. But even though the window is extended, the benefit is still maximum in the first 1 hour. As you can see here, that if you give TPA in the first 1 hour, then you have got 7 times the chances of improvement compared to those who have not received TPA. But as the time goes down, then the benefit also goes down and down and down, and at the end of 4 hours or 3 hours, the benefit is not as much. So even though the window is 4.5 hours, we must try to give it as soon as possible. Therefore, the door-to-needle time must be minimized. Now, International Stroke Trial published in 2012 showed that some benefit lasts even up to 6 hours, but it is only some benefit. Maximum benefit is in the first hour. But what it showed more significantly is that the benefit of thrombolysis extends beyond the age of 80. Normally, there's a little increased risk of bleeding after the age of 80, but if you take the overall analysis, still there is a net benefit. So after this study, everybody is giving TPA even to 90-year-old, 100-year-old with the support of this study. Enchanted trial was published in 2016, which attempted to try a low-dose TPA. You know, in Japan, they give a low dose, it's nationally acceptable, 0.6 milligram per kg body weight. And because of the fear of bleeding, this study was launched. Whether 0.6 is as efficacious as 0.9, which is the conventional dose, but the Enchanted trial showed that it is definitely causes less bleeding, but there is also less efficacy. So therefore, it was a negative trial. But the study mentions that in high-risk situations where you really want to give TPA, you may give this small dose. For instance, if there's a 95-year-old man, or if the patient has just almost at the border of 4.5 hours, or if the infarct is little more than 2/3, in those situations, you may give 0.6 milligram with the less chance of bleeding at the cost of less efficacy also. Now, 2015 was a year of successful endovascular trials for stroke. Escape, Clean, Swift Prime, Extend IA, all of them showed that there is a definite advantage of endovascular treatment of stroke if there is a large artery occlusion. So all these trials concluded that mechanical stent thrombectomy in addition to IV TPA, this is a combo, we have to give them together, not alone, in patients with large vessel occlusion and a small core is the standard of care because it leads to early neurological recovery, better functional outcome with no major safety concerns. So what it established is that in all acute strokes, we should do vascular imaging, we should do whether there's any vascular block, as you are seeing in this patient. And if that is so, then we should also see that there should be the salvageable brain tissue, which is these days seen by a score called aspect score. This is a CT scan. It divides the areas of the brain into 10 regions, as you can see, 10 regions above the ventricle, supratentorial, and 10 regions at the level of basal ganglia. And the total score is 10, which means normal score is 10. But as each one of them is affected by the stroke, and if you see a hypodensity here, then you subtract it from 10. So if it is 6 or more than 6, that means there's enough brain to be salvaged. But if it is less than 6, then you think that it is not worth doing because more than 2/3 of the brain is damaged. But let me tell you, for seeing this, you cannot see it in the routine CT scans which we see it here. You have to see it in a particular stroke window. For that, you have to go to the console itself and see it at a stroke window of 40. Now, the devices have been improving over the course of time. It started with Mercy device, Penumbra device, Solitaire device, and now the latest is Trevo device. And these have made a huge difference in patients who have having large vessel occlusion. So these are the AHA guidelines that patients should receive endovascular therapy with a stent retriever if they have already received TPA, if there is an occlusion of the demonstrable occlusion of an internal carotid artery or proximal MCA, patient should be more than 18 years, and his NIHS score should be more than 6, and aspect should be more than 6. And treatment has to be initiated within 6 hours. These are the guidelines. Now, the current research is to extend this window beyond 6 hours also, and this is the most exciting field. And this is basically based on the fact 3 C's. What is the size of the clot? What is the size of the core? The core is found by the perfusion studies. You can see in this patient, this is the core of the infarct. So that means it is 1/3, but most of it is still salvageable. So small core is a good thing. If you have a small core, then you can think of extending the window. And particularly, you can save this small core if you have got good collaterals. And this is the way collaterals are seen, just by giving IV TPA and IV, this gadolinium, not gadolinium, IV contrast, and you can see they grade the collaterals into various categories. Now, if you see this particular cut, there are no collaterals here. Here there are minimal collaterals, and in this case there are a lot of collaterals. So if you get good collaterals and a small core, then you can extend the window even up to as much as 24 hours. And that was the result which was shown in the DAWN trial, which was presented in early this year, where they showed that based on the core and NIHS mismatch, you can go even up to 24 hours with the help of endovascular treatment, of course. At that stage, IV TPA will not help. You have to do endovascular treatment. Now, another issue has been post-TPA bleed, because we are always worried about it. And there were not very clear-cut guidelines till now how to deal with it. But this is the latest article which has come only last month. And what this article tells about these post-TPA bleeds is that mild petechial hemorrhage following TPA should not raise a concern, but you should keep a close watch on them because they can progress. But usually they don't. But it is the big bleed, a confluent bleed, with or without mass effect, which poses risk. And in these patients, the moment we have detected it, we must give them 10 units of cryoprecipitate pending fibrinogen level. We don't have to wait for the fibrinogen level because it takes at least 1 hour to get that, and by the time there may be extension. In fact, post-TPA bleeds do extend. So therefore, this is the new thing, that there is no need to, you send the fibrinogen level, but don't wait for it. Just give 10 units of cryoprecipitate, and subsequent doses of cryoprecipitate will depend upon what is the fibrinogen level. It has to be brought to at least 150 milligrams per deciliter. Now, can we ignore the gorilla in the room while we are discussing about all this thrombolysis? Can you imagine which gorilla I'm talking about? While we are discussing, something else is happening in the stroke world, and that is the new thrombolytic agent, tenecteplase. So what is the difference between tenecteplase compared to TPA? It is more fibrin specific. It just goes to the clot and binds to it 15 times more than what TPA would do. It has got 80-fold reduced binding to the anti-TPA, which is called PAI, which gives it the advantage of causing less bleeding. And it has 4-fold prolonged plasma half-life. So therefore, you don't have to set up an infusion. You can just give it IV bolus, 1 shot, and it stays on. These are its theoretical advantages. And there are studies which have come in standard journals like Neurology, and they have shown, based on the pooled analysis of 2 major studies which have been done, that tenecteplase causes less parenchymal hemorrhage. As you can see, the red one is tenecteplase, the green one is alteplase. It causes less parenchymal hemorrhage, and also it causes more recanalization, as you can see here. In fact, there are some studies which have shown that the recanalization caused by tenecteplase is almost equivalent to the mechanical endovascular method. Now, they have also looked at the outcome, and there's one of the studies on tenecteplase where the patients have been selected based on CT perfusion imaging, which means they have selected patients where there was a viable core, and in those patients, they have even gone beyond the conventional time window, and what they found is that, again, there was much better NIHS change, much more improvement in the tenecteplase group compared to the alteplase. So the last important trial which was published in the European conference early this year again was a Norwegian tenecteplase stroke trial. It's called NOR-TEST, and it was a multi-phase phase 3 trial where tenecteplase was upfront compared with TPA, and total number of recruited patients were 1107, and the window period was 4.5 hours. So it as closely mimicked TPA as possible. And tenecteplase was given in 0.4 milligrams, alteplase 0.9 milligrams. They found that they are almost similar. There is no difference. The MRS at 3 months, the NIHS improvement, it was similar. If tenecteplase was not inferior, it was not better also. They are similar. So what is the summary of tenecteplase story as of today? Well, as a stroke thrombolytic, it definitely shows promise. It's being given in MI for many years. Cardiologists love it. But even as a stroke thrombolysis, it shows promise. Why? Because of its better recanalization data which we have, and because of the good clinical outcome. Because it is less costly, particularly in Indian setting, and because you don't need an infusion. You can just give an IV bolus and be done with it. But the optimum dose and the window is variable in the various studies. You know, Indian DCGI has approved it, but it has approved it for 0.2 milligram per kg body weight. Whereas in the European study, they have given 0.4 milligram per kg body weight. So we are not sure about the dose. Similarly, in the European study, the window is 4.5 hours, whereas in India, the DCGI has given only window up to 3 hours. So this confusion and uncertainty is there. So I think that wherever it is approved, and as of now it seems to be approved only in India and maybe some African countries, it should be studied further through registries. Few more clinical trials have to be done. It has to come in guidelines. So far it has not come in any guidelines. It is not in European guidelines, it is not in American guidelines, it is not even in Indian guidelines as of now, although DCGI has approved it. Now, the after thrombolysis, let me talk a little bit about stroke unit. And there is enough data for all these years that stroke units definitely improves outcome, whether it is death, whether it is dependency. There is a definite advantage if a patient is treated in stroke unit. The question often asked is, what is so special about stroke unit? Why should a patient improve there? Well, it has been found the main predictor, the main driver of the better outcome in stroke units is the early mobilization. So if a patient is lying in a stroke unit and nobody is trying to mobilize him and he is lying there passively, then probably the outcome will not be good. Most important thing is a focused attention and trying to make patients sit early, stand early, walk out early. All that boils down to the focused attention, and that definitely improves the outcome. And also, because of the focused attention, there's a prevention of the early complications. There's a very important study which came 1 year ago. That is the implementation of evidence-based treatment protocols to manage fever, hyperglycemia, and swallowing. It's called FES protocol. FE for fever, hyperglycemia means sugar, and swallowing means S. FES protocol. And it has been found that if you implement FES protocol strictly, it's an Australian study, the results are as good as even TPA if you take it over the entire populations, because there is no window period, there is no stroke subtype, you can give it to all and sundry. And it forms the crux of the stroke unit care. This is the stroke pathway for the nurses to know it. Because here it is as per a protocol. Measure temperature 4 to 6 hourly, treat temperature if it's more than 37.5, measure sugar level every 1 to 6 hourly, and treat accordingly. Nurses should be trained in this, and all stroke patients should have their swallow screen completed within 24 hours of admission. In fact, as soon as the patient comes, a lot of deaths happen in stroke purely because of aspiration. I think Dr. Kameshwar Prasad in All India Institute has also done a study based on this, which has been published in Neurology India last year. Now, the other thing is that now there is enough data that decompressive craniectomy definitely helps in patients who have got massive hemispherical infarct. There's a Hamlet study, decimal study, all of them have shown a definite survival benefit. But it should be emphasized that the benefit is only in survival. There is not a significant improvement in the functional ability. And this thing should be discussed with the family when we are asking them, not in a hurry, but quite in detail they have to be made to understand. I think there are a lot of cultural preferences. In India, we would like a patient to survive anyway, even if he is dysfunctional. But this has to be explained to patient. And the important thing for, again, decompressive hemicraniectomy is it has to be wide, at least 12 centimeters, and it has to be early, within first 48 hours, not at the end of it by the time the pupils are dilated, then it doesn't help. Now, coming to the venous stroke, we know venous stroke is a good diagnosis. 90% of them respond to heparin, but there is a small percentage, about 5% or even 10%, who don't do well, who have a very malignant course, who come very early, who don't respond to heparin. So for them, the new technique is intrasinus urokinase. And now the latest is even mechanical thrombectomy is done in these patients, but it is not for all patients. There are again criteria developed in KEM Hospital, Mumbai itself, where they say if a patient has not responded up to 1 week with heparin, or if he deteriorates, then one can consider the direct thing. This is our own paper on intrasinus thrombolysis in CV sinus thrombosis, and we found very considerable success in this. Now, what about secondary stroke prevention, which means after the stroke? The new things which we have learned is the word aggressive. We want to be aggressive. So high-dose statin was Perry Emrinko's trial where in his trial called Sparkle trial, he found that 80 milligram statin given after stroke definitely improves the risk of recurrence. Up to 5 years it was done. And why it is aggressive is it is not so much dependent on the level of lipids at all. Even if your lipids are normal, still you would give them statin for so many years. Similarly, another important trial, Progress trial, which used the perindopril and indapamide combination after the stroke and found that there was a significant reduction in the recurrent stroke. And once again, they showed that, again, it's not important patients should have very high blood pressure. Even borderline blood pressure would also benefit. And most important thing is lifestyle modification. And this has been finally, this has been made as one of the evidence-based measures, lifestyle modification, which is measurable. and it was used in Samipris trial, which all of you know. And in that, there are criteria for lifestyle modification, how much a person has to walk, whether he can jog, under supervision. There is a software for that, which is called Intervent. And so aggressive lifestyle modification also is very important part of secondary stroke prevention. It's not that just giving one tablet of aspirin or one statin is going to do the trick. Lifestyle modification has now been accepted and validated as a secondary stroke measure. Now, mechanism-specific secondary stroke prevention have also come up in the last 5 or 6 years. Intracranial atherosclerosis is a very important stroke mechanism all over the world, particularly in China and India, as you are seeing here. And in the Samipris trial, they tested dual antiplatelet compared to intracranial stent, because people thought that intracranial stent may be helped in this, and what they found is that dual antiplatelet was better than intracranial stent as of now, number one. Then there was another trial called CHANCE trial, which is already featuring in the American guidelines. Again, it finds that dual antiplatelet is better than single antiplatelet in these tight stenotic intracranial disease, with the caveat that it is to be given only for 3 months, not indefinitely. It has been found that after 3 months, the chances of bleed go very high, as was seen in the MATCH trial. So if we have to give a combination, there should be a tight stenotic lesion, and it has to be given only for 3 months, after which the patient should be switched to single antiplatelet. Now, what about extracranial carotid artery disease? You can see there's a very tight stenosis here in this picture, and later on it has been revascularized. CREST study compared endarterectomy versus stenting. It was a very huge study, one of the most good studies on this subject. And what it found is that endarterectomy and stenting both are equally effective for preventing stroke. But after the age of 70, probably endarterectomy is better, because their vessels are tortuous and stenting sometimes leads to stroke. So after the age of 70, we may prefer endarterectomy, but revascularization, by whichever method, it is better to be done at 2 weeks and not to delay it too much, because by that time recurrence may happen. In cardioembolic strokes, there have been quite a bit of advancement. It is said now that whenever we have got any stroke of unknown etiology or cryptogenic stroke, we should do their prolonged cardiac rhythm monitoring. And there are many devices for that. There are many new chips for that. There are loop recorders for that. Usually what we do is 24-hour Holter monitoring, but that's not enough. With these loop recorders, you can do it for 1 month, 2 months also, and detect paroxysmal atrial fibrillation. Now, for atrial fibrillation prevention, all of you know that we have got now direct thrombin inhibitors like dabigatran, and we also have 10A inhibitors like rivaroxaban and apixaban. So these we call new oral anticoagulants, or NOACs. And most of these NOACs are by and large same. They are given orally. Compared to warfarin, they have a rapid onset of action within a day. If you give them in the morning, by evening you have anticoagulated the patient, unlike warfarin, which takes 3 to 4 days. They have a predictable effect with fixed or weight-based dosing. They have very less food and drug interaction, unlike warfarin. They are more predictable. They have a short life. There is no regular monitoring required. APTT is not required. So therefore, these definitely seem to be an improvement over the warfarin. 3 major trials have been there, Relay on dabigatran, Rocket-AF on rivaroxaban, Aristotle on apixaban. And by and large, if you see their combined effect, they cause a better prevention of the all stroke and systemic embolism, as you can see on this side of the line. They cause a better ischemic and unspecified stroke, and even their intracranial hemorrhage profile and the intracranial hemorrhage also is less compared to the warfarin. The only thing is that the chances of GI bleed are more with rivaroxaban and with dabigatran, as you can see here. So if a person has any GI bleed issue and all, then apixaban may be better. But one common thing between these newer oral anticoagulants is that we have to be aware of the kidney function. Any person whose GFR is less than 30, we have to be very careful. And below 15, it's absolutely contraindicated. That is one thing we need to check. Now, one problem with these newer oral anticoagulants was that there was no reversal agent. But last year, now we got the reversal agent for dabigatran, which is a monoclonal antibody, idarucizumab, and this is a very effective agent. It immediately binds to the drug and stops its action, but it's expensive. Now, some new developments have happened in the field of rehabilitation. It has been now shown based on the studies that early rehabilitation is useful, but it should not be very intense. If you do intense rehabilitation, on the first 1 or 2 days, it in fact worsens the outcome. So rehab may start, but it should be started gently, and eventually it should be built up. There are also new techniques of rehabilitation like constraint-induced therapy, which you know, in which you tie the healthy hand so that the patient is compelled to use the weak hand. But you need to have some power in it, at least grade 2 to 3 power, then it works better. For aphasia, there is a new melodic intonation therapy, mirror therapy, visual imagery, Botox for limb spasticity, functional electrical stimulation. It depends on the setup one we have. But all these things are evidence-based, there are papers and they can be done. We were part of one study which Jairaj Pandian did in the last 3 years. It was actually sponsored by George Institute, University of Sydney, which was basically designed for resource-poor settings like India and China, in which family members were taught rehabilitation. And one half of the participants did family-led rehabilitation strategy, and other control group got their usual physiotherapy as they do in our physiotherapy setup and all. And at the end of it, after 3 years, they found that there was no difference between the two. Although they thought it was a negative study because they had hypothesized that family-based rehabilitation may be more effective. They thought it was a negative study, but actually if you look at it, they were equal. So I wouldn't consider it negative. I think that if you teach them, they are as good as formal rehabilitation, at least as it is existing in India today. So in summary, friends, these are the main points. Air pollution, gum disease, and sleep apnea are newly emerging stroke risk factors in addition to the existing ones. Thrombolysis benefit persists beyond 80 years of age, and upper age limit is not there. Low-dose TPA has been studied. Definitely it is safer, but it also has less efficacy. But in very high-risk situations like elderly, very elderly, we can, or at borderline window threshold, we may consider it. Endovascular and IV TPA is standard care of stroke if it is because of a large vessel disease. And if a bleed occurs, then we should give cryoglobulin immediately, but before that send a fibrinogen level, and subsequent doses would depend upon the fibrinogen level. The stat dose is 10 units. So in all blood banks, we should ask them to keep cryoglobulin ready. It takes them half an hour to thaw that cryoglobulin and send it to you. So you should keep that in your consideration. And decompressive craniectomy has a role, but it should be wide, it should be early. It may not improve the quality of life, but it will give survival benefit, which should be talked to the family. And stroke unit care with a focused attention on patient with early mobilization has been definitely shown to improve outcome across all over the world. Fever, swallowing, and sugar management is the core of the care. Dual antiplatelets for 3 months in tightly stenotic lesions can be given, but after 3 months we should go back to the single antiplatelet. Stenting and endarterectomy are almost all equal benefit. What you have to make sure, basically I think there are two things. If your patient is more than 70 years, then you will prefer endarterectomy. If he is less than 70, prefer stenting. But more than that, it's important what is your personal infrastructure. Because if your surgeon is very good, then go for endarterectomy. If your stenting fellow is very good, then go for stenting. That the complication should be less than 3%. So go for that. Newer oral anticoagulants are safer than warfarin in non-valvular atrial fibrillation and are probably the way to go. And idarucizumab has come out as a reversal agent for dabigatran. It's very important to know this because many surgeries have been done where this has been, the effect of the dabigatran has been reversed. I know some cases where a patient who was on dabigatran suddenly got a road traffic accident, they had to do immediate surgery, and they had to immediately reverse dabigatran. So we have an agent now. So that may be one advantage of using dabigatran over others, that a reversal agent is available. And home rehabilitation by trained family is same as formal rehab in India. So it may not be a bad idea to teach the family members how to do rehabilitation and depend upon their efforts improving outcome of the patient. So once again, I thank the organizers for giving me the opportunity. I think we have to constantly run to keep ourselves updated for the care of our patients. Thank you very much.
Questions?
Yes, sir. Mike.
Thank you, sir, for a lovely talk. Have we reached a stage where now in the emergency we have to offer either tenecteplase or TPA to our patients, or I mean, what is the evidence right now? Because we are being faced with that, because there are a lot of cost issues between the two. And your comments on low dose versus high dose TPA in the ER.
You see, this tenecteplase versus TPA is anybody's choice in our country. If you do it in America, you are not allowed to do it. If it is UK, you are not allowed. In no country you can do it. But in India, you are allowed to do it. And the data which is available seems okay. And the people who have given tenecteplase, they all are happy with it.
Now come from Scandinavian countries, right, sir?
Yes.
So from Europe, what is their...
Do you have anybody? I think they are not here. The stroke people are not here from Europe. But the Norwegian trial has come. It is also positive only. So we don't have anything as of now which is going against tenecteplase based on the limited data which is available. Now I know people in AIMS have received. Kameshwar Prasad is the biggest supporter of it. In PGI, Vivek Lal has given to 10 patients. So by and large, but we don't have formal studies. Even from India, where DCGI has given approval, the paper is not published. So I have not given to anybody, but I am not close to the idea. I think we can give. After all, in cardiology, it has worked very well. Now your second question is low dose. Ideally speaking, we should give high dose. In a normal, healthy person, able body, we should give high dose because that's what it is. But you know, there are situations where you are a little bit afraid and all, where the infarct size is a little big and all. We have done a further modification. We don't give low dose, we give 1 vial. So that 1 vial becomes sometimes 0.7, sometimes 0.8. I think most of us do like that. So it's okay.
Thank you, sir.
Yes, sir. Yes.
Dr. My patient's son has had a surgery and has a mechanical valve in place, and then he has a bleed. So is there anything new on when to restart the oral anticoagulants all over again? Is there anything new in that?
You see,
what is your...
They have made an algorithm. Dr. Diner has made an algorithm. It's called 2714. It basically depends on how big a bleed or an infarct was there. It depends on that. So if you are asking the patient after infarct or after bleed? Oh, after the bleed. After the bleed, by and large, it is 2 weeks. Everybody is accepted. But if it was a massive bleed, then you may wait for 4 weeks. So I would say 2 to 4 weeks. Small bleed after 2. It depends on two things. That what is the underlying embolic source? If the embolic source is a prosthetic valve, that's a very dangerous thing. So after 2 weeks, I'll give it. But if it was a massive bleed, I may wait for another 3. So 2 to 4 weeks is the range. Yeah.
Call, sir. Thank you very much for a very precise and nice discussion of whole aspect of the stroke management.
Yeah.
You have not touched the neuroprotection. It was deliberate or it was not required to discuss?
No, because there is no positive data on neuroprotection. That's why I have not touched it.
Okay. Because Japanese study, they have, level B evidence for Idaravan.
For Idaravan, yeah.
Only Japanese group is practicing that. So is there any hope in future?
Yeah, I think there is hope. There is hope for that. But as of now, there is not a substantial, impressive evidence. Even Americans have now approved citicoline, but they have got a Food and Drug Administration. So they have approved citicoline as food, not as drug. So as of now, we don't have, but hope is always there. That's why trials are still going on.
Experience regarding thrombectomy after 8 hours, that is as per the Dawn trial?
No, I don't have personal experience for that, but it can be done. If you show that there is a small core, and if you show there are good collaterals, you can do it. But I don't have any personal experience of going beyond 8 hours.
About intracranial stenosis, you said that dual antiplatelets are useful for first 3 months. What makes it less useful after 3 months? And what is the mechanism in first 3 months?
No, basically what they see is that the maximum chance of recurrence in any stroke is more in the first 3 months. It's more in the first 1 month. After that it becomes less. It has been found that the bleeding complications are much more after 3 months. All over the longitudinal studies have said that most of the bleeds have happened 1 year after or 1.5 years after. So it is a kind of a trade-off. So you are trading off the anti-clotting mechanism, early anti-clotting mechanism to prevent bleeding later on. So that is the thing. That is why they have done this kind of a compromise formula. Otherwise, it would be always effective to prevent a ischemic stroke, but at the cost of causing bleeding. Let's say.
Just to add one comment, sir,
Yeah.
about tenecteplase. Actually, I am from King George Medical University, Lucknow, and we have been using both the things, tenecteplase as well as alteplase. We offer both the things to the candidate, and if one is able to afford alteplase, we go ahead with the alteplase, and if not, he is ready with the tenecteplase, then we use tenecteplase.
So which is better according to you?
I found both the agents equally effective.
Equally effective.
Equally effective.
Yeah. So.
Dose of tenecteplase 0.2 mg
0.2.
per kg body.
That's the Indian dose.
Same dose.
So, what about using newer anticoagulants in CVT? We see a lot of CVT patients, and warfarin related issues are difficult for them to follow.
I think you can use it. You can use it. It is not in guidelines, but I have talked to a lot of experts, including Louis Kaplan. You can use it, but you have to document it and explain to patient and give your reasons why you are using it. I think Thomas Matthew from Bangalore has published also.
Yes, sir.
So you can use it, but document it.
There are no legal issues with using.
There are no legal issues if you take a documentation and explain to patients.
All
now,
right.
legal protection is one of the part of our practice. So, because it is not recommended as such, therefore it is better to take, but it works. As per everybody who are in the field, it works.
And which one would you choose among the newer ones?
You see, it depends. I think there are only two things in this. If a patient has a GI problem, history of GI bleed, this thing, then I would straightway go for apixaban, because it doesn't have extra GI bleeding which the others have. But if that is not an issue, I would choose dabigatran for the simple reason that it has got an effective antidote. That's it.
All right. Thank you.
Sir, I received one patient with 40 kgs, and he was suffering from pulmonary tuberculosis, sir. He took medicine, he took ATT for 2 months, then later he stopped. So patient had CVA, CT was negative, but he had hemoptysis 2 days prior to the CVA, sir. In such patients, whether we should proceed to the thrombolysis or to...
No, the question is that you are saying the contraindication because of hemoptysis? That is the reason?
Sir.
In all such patients where there are contraindications, particularly bleeding contraindication, you cannot give IV TPA. That is out of question. Any bleeding within last 14 days, you cannot give it. Unless you know the cause and you have corrected. Otherwise you can't give it, but you can do mechanical in these cases. So mechanical, if you have got availability of mechanical thrombolysis, all these contraindications go away. That's a big boon. But not IV TPA, because he'll bleed.
Thank you, Professor Kaur.
Thank you, sir.
We'll break for the tea.
Thank you, sir, for this enlightening talk. I would request Program Director Dr. Ramesh Patankar to please felicitate Dr. Kaul for his speech.
advertising those for they have the pet.
And the Grammy.
Hello. good afternoon. We begin with Professor Lakshmi Narsihan. He is well known to all of us. He is currently Director and Professor at Madras Medical College. He has received multiple awards, namely Palatuki Award from American Academy of Neurology, prestigious A.B. Baker Presidential Award for Global Best Teacher, Best Teacher Award in Neurology from MGR University. He has got multiple publications, nearly 40 publications, of which 13 are international. He is a member of editorial board of International Journal of Epilepsy. He is editor of Cochrane Epilepsy Group, assistant editor of Annals of Indian Academy of Neurology, and advisory board member of BOG Neurology Journal. Welcome, Dr. Lakshmi.
Good morning, everybody. At the outset, I thank the organizers for giving me a chance in this prestigious forum. And unfortunately, this is the most dry topic where I wouldn't know whether I would be able to sustain the interest of all of you on this topic. But just at the outset, I would like to tell that the pain is a very complex feeling where a lot of gender differences are there. Both male and female react to pain differently, and not only that, it is the situations also decide how do you react to the pain. But I was just wondering, these are all subjective, but I was surprised when I went through the literature that there are even the genetic differences in the expression of few things in male and few things in female in the pathogenesis of neuropathic pain. I was surprised about that, and in fact, even a few of the kinase receptors on the Pacinian corpuscles have some gender differences. Anyhow, neuropathic pain is, in the simplest way, is a pain caused by a lesion of the somatosensory system. Anywhere, somatosensory system, the lesion could be A beta, A delta, or C fibers, and the spinal neurons. 7 to 10% of the whole population. It's a huge, most people affected by neuropathic pain is 7 to 10. 7 to 10 is a big number. As you know, that lot of insights have gone in these areas where touch, pain, pressure, temperature, vibration, position, movement, which are all the nerves of the skins and muscles, the nerves of the fascia and the joints, and the various receptors like thermoreceptors, prurireceptors, mechanoreceptors, chemoreceptors, and nociceptors. Here, the point to make, what is happening is, they are identifying genes which control these receptors, which straight at the point of entry of pain, how they modulate how the pain at the entry point itself, it is gated. And it is complexly genetically wired at that point of insert. Each receptor, for example, even Pacinian corpuscle has a kinetoreceptor gene on a locus which controls how you react to things. And interestingly, there was one family, it's called, all of you must be aware, this is the Marcelli syndrome, where 7 Italian families who, none of them had pain. They never required anesthesia for major surgeries. They had fractures and all this, and then they finally narrowed down to a monogenic problem in the entire family that has caused this congenital absence of perception of pain. So neuropathic pain is a severe chronic disease that follows any injury to the somatosensory, characterized by spontaneous pain, distortion, and exaggeration of pain, and peripheral nerve pathologies are considered generally easier to treat compared to the central pain. Already you have heard a lecture. So the central nervous system, it could be a brain where the post-stroke pain and the Parkinson's pain of Parkinson's also comes into the central neuropathic pain, where it's a very big topic on its own self, and spinal cord injuries, syringomyelia and other demyelinating disease in the spinal cord, and peripheral nervous system, peripheral neuropathic process, complex regional pain syndromes, and the various. Just to take you that in the peripheral, you see the distributions of each of them. trigeminal neuralgia where the pain is confined there, the post-herpetic neuralgia along the unilateral distribution of any of the dermatome. The peripheral injury pain could be here depending upon the site of injury or the surgery, or the missing body part of the residual limb, the post-amputation of the phantom pain. There is something called reverse phantom, which I just anecdotal in drawing to the attention. The phantom pain is because if pain, perceiving the pain on a non-existent part where you got amputated. The reverse can also happen where a part of the homunculus is missing and they have, the part is existing but it is not represented in the brain. The input, continuously the input goes to the brain and they were not able to do what to do with the, so much of afferent input goes to the brain, but that particular part is missing in the homunculus, sensory homunculus, and it produces so much of stress to that amount that they wanted to amputate that limb, because it is, then functional MRI studies have revealed that this homunculus was missing. This is called reverse phantom, and now it's being treated with the mirror therapy and has avoided so much of amputations. There is about almost 100 to 150 amputations happening. People migrate from US to Canada to get the amputated, and finally it landed up, they found out that this part of the homunculus itself is missing from birth, and that has resulted in the conflict, and that has resulted in so much of stress on the persons. Okay, and here there is one channelopathy is also which comes under this neuropathic pain, which is a rare erythromelalgia, where there are two things in this. One is SCN9A mutation, is a sodium gated channel, generation which is involved in the generation of conduction action potential, and pain and erythema of extremities. A similar one where paroxysmal extreme pain in the sacrum and mandible to one of the similar mutation, the SCN, where there is redness and mutation, and the presentation is like the low back pain on the sacral area. This is again a SCN mutation, which is also comes under neuropathic pain. So what are the newer things which is happening in the pathogenesis? I have just divided them into the pathogenesis and newer things in the investigations, and what are the newer things in the treatment. So and whatever be the triggers, the mechanisms involving the pathophysiology involves glutamate, GABA, and the adenosine. It could be a stimulus-evoked pain like allodynia, or absolutely stimulus-independent pain also. They're classified as peripheral, spinal, and supraspinal. Peripheral, as you know, there are so many channels, the capsaicin, the acid ion channels, PGE2, bradykinin, all this. Each one has the receptors are complexly interact with this. Various receptor nerve terminals in the transduction of signals in the sensory signal transmission. And essentially, neuropathic pain is because of the imbalance between the inhibitory and the excitatory signals. And second important thing in this is the spontaneous ectopic production of impulses at that place. And the third thing is the alterations in the channels. So we have to hit at one of these three, whether you correct the imbalance or hit at the prevention of this ectopic focus firing. And the third is the look at the channels. Ectopic activity in the primary afferent fibers might have a key role in the pathophysiology of neuropathic pain following peripheral nerve injury. Hyperexcitability in the neuropathic pain due to changes in the channel function as well as expression. And increased expression and function of the sodium channels in the sensory nerves cause excitability and signal transduction and neurotransmitter disease. Whereas loss of potassium channel that normally modulate the neural activity is present, causing remnants of the fibers at the injury site to generate ectopic activity. So in the spinal neuropathic pain, it is again enhanced excitability of the spinal neurons. The enhanced receptive field of the receptor and hence activates more nociceptive second order neurons. That's what produces the central sensitization. As you must have, even in migraine and all, you would have, most of the patients would have complained that because of the central sensitization, the non-noxious stimuli producing so much of pain, even combing the hair and all these things produce so much of. Increased NMDA and AMPA and decreased GABA, that increases the excitability of nociceptive second order neurons in the spinal cord. The role of, here previously it was thought that the glial cells, where there are 3-4 mechanisms which they are looking into in the pathogenesis of neuropathic pain. One is there are three mechanisms involving the microglia. One, whenever the neurons get damaged, the ATPs which are released, which activate the purinergic receptors and release the brain-derived neurotropic factor and diminished inhibitory signaling from GABA, and that results in perception. The second mechanism is when the dorsal root ganglia get injured, the colony stimulating factor is released, which enters the spinal cord, which acts on the receptors in the microglia, and the microglia starts proliferating and modulates the pain. And the third mechanism is the phagocytic cell activation and calcium channel, shortening of the GABAergic interneuron terminals, and loss of GABA-mediated inhibitory transmission and increased pain perception. And the astroglia acts through the interleukins as well as the chemokines and CCL2, and oligodendrocytes acts through IL-33. So there are three microglia, the oligodendrocyte as well as the astroglia, all have roles in the genesis of the neuropathic pain. As I told you, even the glia and the sex differences is the classical pathway involving the P2X4 and P38 BDNF, and disinhibition of the spinal GABA-mediated transmission contribution to neuropathic pain occurs only in males because of the genetic differences. This is, and second thing is, in the females, the T lymphocytes expressing the PPAR gamma drove to the hypersensitivity. In the supraspinal components of the pain is here, as you know, that all of us are blessed with cannabinoid receptors, and the very fact that we are blessed with cannabinol, that means that we must have the some way of production of cannabinoid substances within ourselves. Endogenous production of cannabinoid should have been possible, and our yogic things say that the meditations and other things can stimulate the, like endorphins, the cannabinoids can be stimulated in the brain, and so the areas which are involved in the pain, apart from the primary somatosensory cortex, the inferior parietal lobule, thalamus, and the dorsolateral prefrontal cortex, and lot of portions of the limbic system, because every time when you have a pain, the first one to react is your limbic. So numerous studies have shown that the brainstem excitatory pathways are important and in the maintenance of the pain state than in its induction. Noradrenergic inhibitions attenuated in the neuropathic pain, and patients who the facilitatory pro-nociceptive profile could be treated with a drug that facilitates. The GABA pentinoids act in this area. And similarly, there is a role for SNRIs also. So this is a very busy circuit. I just wanted to show you that if you look at the peripheral nerves and alter top, they alter the transduction and transmission. In the spinal cord, what they do is integration of these messages and amplification and modulation. And there are descending controls. There are two things in this. One is the periaqueductal gray as well as the ventrorostral medulla. They do the gating. Both have dual gating properties where they can be inhibitory or facilitatory. And I will come back to that system a little later. And amygdala and cingulate cortex and nucleus accumbens are involved, and they are involved because of the reactions to the pain, and the somatosensory cortex via the thalamic relays. So these are the parts, and there are many circuits. If you look at the limbic pathway, the spino-reticular and the dorsal column pathway, spinothalamic pathway, the noradrenaline pathway, pain facilitation pathway, pain suppression pathways, and the thalamic relays are the various things involved in the signaling. So approach to the neuropathic pain. When you know it's possible neuropathic pain or unlikely to be neuropathic pain, you should understand that we are very successful because we are able to, especially in the pain management, we are very successful than most of the orthopedicians and other colleagues. We always pick up the inflammatory. We understand that the inflammatory chronic pain is different from the neuropathic pain, and the normal NSAIDs have very, very little action on the NSAIDs, have little action on the the neuropathic pain. So unless you treat with drugs which are very effective on neuropathic pain, the pain is not going to go away. And if you look at the newer things on the investigatory modalities, this corneal confocal microscopy and the punch skin biopsy are the two newer additions apart from the various quantitative sensory things. The laser evoked potentials, as you know that laser evoked potentials is the one by which evaluates the spinothalamic tract, whereas the central motor conduction time which evaluates the corticospinal tract, and SSEPs evaluate the posterior column, and similarly the laser evoked potentials evaluates the spinothalamic tract. The blink reflex, nerve conduction studies, and the somatosensory, these are the two investigatory things. And the corneal confocal microscopy, the data on this correlation with the peripheral neuropathy is pretty limited, but it's a non-invasive in vivo technique and can be used to quantify corneal nerve fiber damage in patients with peripheral neuropathy. Coming to therapeutics, the various receptors of the nerve terms which I told you, these things you know that the tricyclic antidepressants act at various these points, the anticonvulsants act here, and the opioid and the modulation by opioids. These are the three right now the big players on this. The pregabalin and the gabapentin also come under this second group. But what are new in store is the cannabinoids, the stem cells, and the chemogenetics. Cannabinoids, as I was telling you about this, that every emotion has a chemical. For example, happiness has what is called anandamide, and based on the Sanskrit word anand, anandam means extreme happiness, and similarly the anger is called virodamin. These are all chemical compounds named, these are all internationally, this was, there was a mention about this Jackie Wasdev on one of those things that he was initially talked about the ways and stimulating the endogenous cannabinoids, and one of the Nobel laureate who was involved in the various cannabinoid components had named this based on this Sanskrit inscription. Anandamide and virodamin are chemicals which are involved in the central nervous system dealing with the emotions. So the endocannabinoid neuromodulatory system, which is present in our brain, constituted by the cannabinoid receptors and arachidinoethanolamide, it also plays a role in the short-term memory. It also a role in panic reactions, motor coordination, food intake, and pain perception. So tetrahydrocannabinol accounts for most of the psychological and the physical effects, and the cannabinoid has CB1 and CB2 receptors, and the increased mitogen activated protein kinase, it modulates calcium and potassium, and that results in reduction in the neurotransmitter release and decreased firing. So the CB1 is the this is the one which I was telling you about, the periaqueductal gray matter and the rostral ventral medulla and the dorsal horn of the spinal cord. This system is involved in the gating of your pain. This is richly innovated with the cannabinoid system and CB1 receptors, and this system can be inhibitory, can be facilitatory, and this is the system which dual way it modulates the afferent input. So whatever impulses which you get, painful and other things, are gated by this system, which has descending connections to the spinal cord from the periaqueductal gray and the rostral ventral medulla. And the cannabinoid 2 receptors had a lot of receptors are expressed in the peripheral immune system, where the T and the B cells, macrophages, and natural killer cells, and a lot of cannabinoid 2 receptors are in the dorsal root ganglia and the central level of the spinal cord. So now you will understand why cannabinoids are going to play a big role in the management of neuropathic pain, because the receptors are so much in the dorsal root ganglia, the receptors are there in the descending gating system, the dual gating system, which is responsible for facilitatory and the inhibitory impulses of. So I'm sure that this cannabinoids has going to have a role in the neuropathic pain. Not only that, it also acts through the non-cannabinoid receptors, that these cannabinoids also have a role on GPR55 and TRPV1. The TRPV1, if you know that They also have the tactile receptors on the peripheral nerve also has this vanilloid receptors. So definitely the paroxysmal proliferative PPAR and all the three can also have these actions. So cannabinoid seems to be useful in alleviating neuropathic pain after prolonged treatment, unlike opioids which show only limited effectiveness. Activation of cannabinoid receptors by the synthetic agonists and the pharmacological elevation of endocannabinoid levels suppresses the hyperalgesia and allodynia in various animal models. Most of them, except for the cannabinoid, the other things, two things which I am going to talk are in the experimental stage in humans. I do not know, at the outset I put a disclaimer that I don't understand whether it's a rodent pain is equal to a human pain. And just because something acts on the rodents, it may not be the translational the research. I will be surprised that might fail the human trials because our reaction to pain is entirely different and complicated than the primate trials. So most of them have just entered the human trials. The CB2 receptor activation exerts anti-allodinic and anti-hyperalgesic effects by modulating microglia responses, and activation of central CB1 receptors leads to a combination of stimulatory and depressant effects. Synthesis of CB2 receptors, selective agonists which lack majority of central side effects, produces anti-nociceptive effects, representing an interesting pharmacological tool because most of the CB2 receptors are in the periphery, especially in the dorsal root ganglia. And this is going to be the drugs which are going to act on the CB2 receptors, cannabinoid 2 receptors, are going to play a major role in the next 1 decade in the management of neuropathic pain. So a selective activation of CB1 or CB2 receptors and enhancement of the endocannabinoid levels can be a promising therapeutic approach that avoid the side effects associated with the central CB1 receptor activation. So I would vote for a CB2 receptor activation than CB1 because CB1 has a lot of central side effects because it is closer to the brainstem, the periaqueductal gray and the rostral ventral medulla. The vomiting and all other side effects are likely to be higher. The second entity is the stem cells in the neuropathic pain. The damaged peripheral nerve demonstrates some potential to regenerate. However, complete functional recovery is infrequent. Research is focusing on newer cellular and molecular approaches such as stem cell therapy. Stem cells are there everywhere. But in this area, the lot of interesting things which has come is they improve the intrinsic regenerative capacity of the injured nerves. They inhibit pathogenic immune responses both in the periphery as well as in the CNS, in the releasing neuroprotective and anti-inflammatory molecules favoring the tissue repair. So what are the source? You know that the lot of bone marrow based, so the mesenchymal stem cells are the most ideal in treatment for the peripheral neuropathic pain. And I don't want to go into the details. So the population of progenitor cells of mesodermal origin are found in the bone marrow of adults, which give rise to skeletal muscle cells, blood, adipose tissue, vascular, and the urogenital and the connective tissues throughout the body. It yields the most prominent results in peripheral nerve regeneration, and it is potential as therapeutic agents since they are easy to isolate and can be expanded from patients without serious ethical and technical problems. And some transplanted stem cells assumed a Schwann cell-like. So myelin repair, it's going to play a role in future because most of these mesenchymal genes have a tendency to become a Schwann cell-like cell and produce this. So the bone marrow derived mononuclear cells is capable to alleviate neuropathic pain in the early stages. It's been proved, especially in diabetic neuropathy, the trial is, human trials have started where BM-MNC transplantation significantly ameliorated the mechanical hyperalgesia and allodynia. So tissue engineered bioabsorbable nerve conduits coated with the pluripotent stem cells derivative neurospheres, they were able to repair the peripheral nerve gaps in the mice. Cell incorporation into conduit repair of peripheral nerves demonstrates experimental promise as a novel intervention. So this is they've definitely proved this in the animal experiments, and it is now they are going into the where the conduits are coated with pluripotent cell derived neurospheres, and they are using that. So induced pluripotent stem cells technology has enormous potential to advance medical therapy by personalizing regenerative medicine. So enhancing the intrinsic regenerative capacity, as I told you, why it is going to be playing a role in the future is because it has the ability to differentiate into Schwann cells, it secretes neurotropic factors and assist in myelin formation. So all these three make me feel that the next decade there is a role for this induced pluripotent stem cell coated with or without the spheroids. The concerns and the pitfalls are, as I told you, insufficient human studies, possible negative and harmful effects of the transplanted culture cells, graft versus host disease, we don't know because not many studies are there, but very, very promising reports when I went through the various newer insights. These are the things which I found. And finally, coming to the chemogenetics, where is again a molecular approach to regulating the neuronal function. Specific populations of neurons are administered a virus. As you know that the adenovirus is associated adenovirus vector is a very established vector for the carrying any endogenous molecule. The channel receptor is mutated, it is selectively engaged by a drug, and so this is a way where you want to silence the chemogenetics is silencing the neurons by using these vectors. What they do is the adeno-associated virus-based chemogenetic therapy is used for treatment of peripheral nerve injury-induced neuropathic pain. The examined CNS neurons are transfected with a modified heteromeric invertebrate glutamate-gated channel. The glutamate channel is transfected with the AAV virus, and after transfection that a low dose ivermectin administered which prevented action potential generation and inhibited potassium evoked depolarization of the sensory neurons. So this ivermectin induced neuronal silencing did not develop tolerance on repeated dosing. So this is what they do is they give the transfecting the intrathecal injection of the AAV virus, which were the glutamate chloride channel, and you can see that they are homing into both the soma as well as the neural compartment very effectively, and then treating them with challenging a systemic dose of ivermectin results in lowering the nerve traffic as well as the increasing the threshold for pain, and which does not have tolerance. So even on repeated dosages, they were able to replicate these results. So no fear of generating a deafferentation pain or anesthesia dolorosa, an effective pain control on repeated dosing without tolerance, limited side effects, and less misuse potentials. So, in my opinion, these three things, the cannabinoids, the chemogenetics, as well as the stem cells, are going to be in the next decade of treatment of neuropathic pain. Thank you for your attention.
Any questions?
Thank you, organizer, for keeping this atypical topic here. Yeah, but although you are not interested to present this, but you have dealt it very nice manner.
Thank you, sir.
Now the thing is that although somatic pain or nociceptive pain and neuropathic pain is different, but sometimes they are mixed, particularly when there is mechanical injury to the nerve. We are, lot of our person are dealing with radiculopathy and entrapment neuropathy. Possibly it is here. It starts with nociceptic or somatic pain and then goes to the neuropathic pain. And that's why short course of corticosteroids can be helpful in radiculopathy and all type of entrapment and traumatic neuropathy. Initial part is that of inflammatory, and latter part, because of mechanical and compression, it's a neuropathic nature.
Thanks for your comments.
Okay, thank you, sir.
And one more interesting thing is, as you know, that pain and pleasure compete the same pathway. So immersing you into a pleasurable environment definitely modulates the pain. So now in virtual reality, the immersion therapy is also really gaining a lot of potentials, because almost the younger generation people, most of them have this VR environment. So you can provide them with desktop environments where they can immerse themselves into pain. Even there are studies being published where acute migraine can be treated with virtual reality immersion therapy using VR glasses. Excellent. Thank you.
Thank you, Professor.
Thank you, sir.
Next talk is by Professor Martin Deschens. I welcome, he's already introduced yesterday. Please come, sir.
Good morning. I'll continue where I've stopped yesterday, and those who were not here yesterday it was about small vessel disease and its impact on stroke and dementia. And the topic for this morning is vascular cognitive impairment, which actually has an even broader implication, especially in the elderly population. What I would like to talk about, after briefly going over my disclosures and moving to the agenda, what I would like to talk about this morning is shown here. So I'll start with the frequency of vascular cognitive impairment, which again is the second most frequent and important cause of dementia in the elderly population. It's gaining in importance as our societies all around the world are aging. I'll then speak about the clinical characteristics, then go into quite some detail regarding cognitive testing, because there has been some development in the recent past in terms of brief cognitive screening tests and how to apply them, in particular in patients with stroke, also via telephone. So I'm going to familiarize you with aspects I would consider to be practically relevant for your clinical practice. And then I will move to mechanisms, just as I did yesterday, again speaking about sporadic disease and genetic forms of vascular cognitive impairment, and finally end with prevention and dementia. So the question, what can we actually do to treat these patients and to prevent the occurrence of vascular cognitive impairment? So I will start off with post-stroke dementia and post-stroke cognitive impairment. And this slide, which you may have seen before from other presentations, shows you the frequency of post-stroke dementia in this case, clinic-based samples, so population-based samples. So what the key numbers to remember is that 10% of our patients who develop a stroke are already demented at the time of their stroke. 20% of individuals who experience a stroke become demented as an immediate consequence of their stroke. That's population-based data. And after that, the incidence rate of dementia maintains quite high, 3% per year. So that there's a massive problem with stroke causing cognitive impairment and dementia, and even the long-term consequences are very relevant, and we're just learning to see sort of the full scope of the whole picture. Now, one important aspect to realize is that there is a problem in the acute phase of stroke that is called delirium, so an acute confusional state that should not be mixed up with post-stroke dementia, even though it is a risk factor for post-stroke dementia. And as a rule of thumb, about 1/5 of individuals with stroke do develop delirium. This is shown here in this relatively small study. On the left, you see that 50 out of those 263 patients with an acute stroke develop post-stroke delirium, again, acute confusional state. And among those who develop post-stroke delirium, there's an even higher proportion who then move on to develop dementia. So delirium is frequent, and it is a risk factor for developing post-stroke dementia. There are also risk factors for developing delirium, and this is a large infarct, this is a low educational level, and pre-existing cognitive impairment. So in particular, elderly patients who are already demented or, not demented, but cognitively impaired, for example, on the basis of comorbid Alzheimer pathology or vascular cognitive impairment, they have a higher risk to develop delirium, and those who develop delirium in the acute phase of stroke are at high risk to move on to develop dementia in the following years. So this is delirium. There's another phenomenon, this is called transient cognitive impairment, and this is sort of the counterpart of TIA, transient ischemic attacks. So some patients with an acute ischemic deficit do develop transient cognitive deficits that don't qualify for delirium. And in this case, it was operationalized as a Mini-Mental score at least 2 points below the Mini-Mental score when tested again 30 days after the acute stroke. And what you see here is that transient cognitive impairment occurs in patients with a TIA, that's the white bar, in those who have a resolved stroke and those who have an unresolved stroke. And the incidence or the prevalence of TIA is higher in the first week, transient cognitive impairment is higher in the first week after stroke than if you test 8 days or later after stroke. So it really corresponds to the phenomenon of transient ischemic attacks. So you have delirium, it's a short confusional state, and you have transient cognitive impairment, which does not necessarily need to be very severe. So it's frequent, it's independent from focal neurological deficits, and again, like delirium, transient cognitive impairment is an indicator for the risk of developing dementia in the future. Now, what are risk factors for incident dementia after TIA or stroke? First of all, there are demographic factors. Of course, there's age. And then probably the second most important risk factor for developing VCI after stroke is diabetes. This is from a series of slightly more than 1,000 Chinese patients originally seen and collected by Vincent Mock. In Singapore, 88 of those developed incident dementia 3 to 6 months after stroke. And again, in this series, it was mostly age and diabetes that turned out to be demographic risk factors for the development of post-stroke dementia. Among the imaging factors, it's mostly white matter hyperintensity volume and the presence of medial temporal lobe atrophy, seen here on the bottom images, which you might say is indicative of Alzheimer's disease, but as you will see in a minute, it's not only reflecting Alzheimer's disease, it's probably a more general indicator of, again, it's brain atrophy of pre-existing brain damage. Anyhow, individuals who have white matter hyperintensities and who have medial temporal lobe atrophy are at a substantially increased risk of developing dementia after stroke. This is from a smaller series of individuals that we investigated in which we did amyloid PET after the acute stroke. Overall, these were 56 individuals, and out of those, 38 qualified for mild cognitive impairment. So they were cognitively impaired. On average, these scans were obtained about 3 months after the acute stroke, and what you see here is that the rate of amyloid positivity is not increased in patients with mild cognitive impairment after stroke, indicating that it's not underlying Alzheimer's pathology that contributes to cognitive impairment after stroke. It's mostly other factors, and I've given you a few examples here. So the top 2 rows are patients who develop post-stroke MCI, and what you see here is that on the top it's a 56-year-old male patient with a relatively large MCA infarction who developed post-stroke mild cognitive impairment but was amyloid negative on large. Below, in the middle row, is an individual who had nothing else but a pontine infarct, who was amyloid positive and who developed MCI. It's difficult to imagine that the cognitive impairment originated from his paramedian pontal infarction. But again, the rate of amyloid positivity was not significantly increased. Actually, it was nominally lower in patients with post-stroke MCI compared to those who did not develop post-stroke MCI. And you know that especially in an elderly population, the rate of amyloid positivity indicating ongoing Alzheimer's pathology is very high, in the range of 8 to 10% even in elderly subjects. And on the bottom row, there is a cognitively normal individual who, again, you see the infarction on the left, who was amyloid positive but still did fine cognitively. So the correlation between amyloid positivity and cognitive impairment after stroke is very poor, and in most instances there must be other reasons than Alzheimer pathology explaining the cognitive deficit, and we think it's vascular. This is another important aspect. So far we've been speaking about ischemic stroke. Now moving to hemorrhagic stroke. As you know, this is the most disastrous form of stroke. It's strongly associated with small vessel disease, about which I've talked yesterday. And this is probably the largest and best series of 218 patients with ICH and no pre-existing dementia who was alive 6 months after ICH and then followed for the incidence of dementia over 4 years. And what you see here on the bottom left is that the rate is very high. On average, 28% move on to develop dementia within 4 years after an ICH. And the rate is particularly high in individuals with a lobar hemorrhage as compared to a non-lobar hemorrhage. Additional risk factors for developing post-stroke dementia after ICH are leukoariosis, so again, white matter hyperintensities, a history of a previous stroke, a recurrent stroke, and so on. So again, the risk of developing dementia after stroke is very high. It's particularly high in ICH, and it's particularly high in those who have cerebral amyloid angiopathy and lobar hemorrhage. I'll now move to cognitive testing. As you remember, or as you're certainly aware, in many cases this is not done. It's not done in clinical trials, and it needs to be done, and most people now agree that it should be part of clinical trials endpoints in stroke, and it's important. Now, but it's not trivial, because it takes time, and because choosing the right test battery is really essential. There have been, and this is from an article published in Nature in 2012, there have been instances where choosing the wrong cognitive test battery has jeopardized the results of clinical trials. So, for example, if you are going to test patients with vascular disease, you need to include processing speed and executive function items. Otherwise, you will miss especially the subtle cognitive deficits in patients with MCI. And again, if you are dealing with a test that has a ceiling or a floor effect, you will not pick up and you will mess up with the results of whatever you do. So there has been a group, and I was lucky enough to be part of this group many years ago in 2006, that came together to define cognitive test batteries and standards, how to test patients. This was the NINDS, Canadian Stroke Network, VCIA Harmonization Standards Workshop. And there are a number of criteria important to keep in mind when you test patients. It's the quality of the standardization sample. It's the qualities of the psychometric test battery. It's portability, so it should not be a large, a large folder. It should be a small, ideally only 1 or 2 sheets of papers. It should be brief. The costs are an issue. Ease of use, domain specificity. So is it representative of what you are going to test, and especially applying to your particular population of patients? There must be multiple forms available. I'll get to that in a minute. So it must also take account of, cultural aspects, language aspects in different continents. This is the aspect of international or cross-cultural capability. Again, there should be no ceiling or floor effects, and it should have been used in previous VCI samples. Now, these are 2 individuals here. I'll go back, and on the left, you see a gentleman who has severe vascular cognitive impairment. Actually, it's a patient with CADASIL. And on the right, you have a patient with subjective cognitive complaints, but who turned out to be cognitively normal upon detailed cognitive testing. And the test I'm going to show here is the so-called trail-making test. All individuals are asked to do is to connect digits and numbers in an alternating order. And you will see, going back, that the gentleman on the left takes an awful long time to achieve the task, whereas the gentleman on the right does just fine and completes the task within 20 seconds. Gentleman on the left eventually took 2 minutes, needed various reminders, and this is a very sensitive test of processing speed and executive function. And it is part of the Montreal Cognitive Assessment Tool, the MOCA, which is available freely downloadable via the internet, translated in multiple languages, and it is really very well suited to test patients with vascular cognitive impairment because it includes not only the trail-making test, but also other processing speed items that are so important in this group of patients. But even if you use the MOCA and you think about it carefully and deal with these patients, you will run into issues. Those are listed here. First of all, there are multiple test batteries. So even if you decide for the MOCA, there are other test batteries like the MMSE, the TICS, and so on. Maybe there's good reason to decide on the MOCA. But then there are multiple test versions. Also, for example, the telephone MOCA. There are modified versions of the TICS. Then there are variable MCI definitions, so single versus multi-domain. Do you judge a patient to be cognitively impaired if he has deficits in one single cognitive domain, like processing speed, or do you request him or her to show deficits in multiple domains? And then how do you define a deficit in a single domain? Do you require multiple test items for that particular domain to be abnormal, or do you just require one single domain? So there's a lot of controversy about this, and the field is not agreed on it. This is an illustration of the cognitive profile 1 year after TIA or stroke in only 91 non-demented subjects who were tested by multiple test batteries. And there are three lessons from this relatively small series. First of all, almost half of the patients did develop MCI according to this broad test battery. Second, the most frequent abnormality was non-amnestic MCI, so not requiring or not even involving memory deficits. As you know, memory deficits are required in patients with Alzheimer's disease to establish a diagnosis of MCI in Alzheimer's. In VCI, it's not an early abnormality. It's typically processing speed and executive dysfunction. So you may diagnose MCI in the absence of memory deficits. And the third lesson here is that the agreement between subjective memory complaints by the patients and abnormalities on testing was relatively poor. You see this on the left and on the right here. So the numbers don't match well. Now, what about the predictive value of baseline MOCA? Baseline MOCA meaning that you test the patient in the acute phase of stroke. I know it's challenging because it takes time. Also, there are technical difficulties, particularly in crowded rooms when there are multiple patients. But it's very informative, and we have now started to do this on a regular basis in our patients. Why? Because it's predictive of future prognosis, as you will see in a minute. These are unpublished data. We're just writing the manuscript. So what we did here is we went into 2 prospective studies targeted to identify predictors for stroke, DEDEMAS and STROKE-DEM, conducted in Munich and Lille. We tested them at baseline, then went on to test again at 6 months, at 12 months, and at 36 months. And of course, we lost patients because patients died, because patients didn't return to our center, and for whatever reason. And these are the data for the DEDEMAS cohort, for the STROKE-DEM cohort, and for the pool data set. And what you see here is that baseline cognitive testing by the MOCA and using a cutoff of 26 is predictive of cognitive impairment in the future, of cognitive performance in each individual cognitive domain, a functional impairment measured by the modified ranking scale score and IADL, and by all-cause mortality. Actually, we found the MOCA at baseline to be even more predictive than the NIH stroke scale score, so really very, very important to conduct, and it's important to perform these tests at baseline. Now, if you don't manage, or even if you manage to test at baseline, you may also consider to test patients again, for example, after 6 months or 12 months in a prospective study, which you're conducting here, from what I understand. And then it's much more convenient to use telephone tests, and there are telephone tests. There's the T-MOCA, and there's the TICS. And what we did here, this was a published, a prospective study published, I think last year. So we had about 100 patients. We invited them to return to our center, and then we did detailed neuropsychological testing. This is the broad bar here in the middle. But before that, we did telephone testing via T-MOCA, and we also tested them after the visit via the TICS. And in the second group, we did it in the reverse order, just for methodological reasons. And then we determined the sensitivities, the specificities, positive and negative predictive value of the TICS and the T-MOCA for any MCI and multi-domain MCI, again using all those variable definitions. And what we found is that if you want to test your patients, you're well off if you use the TICS with a cutoff of 36. It has high sensitivity and high specificity, particularly for multi-domain MCI. So again, here you look at MCI with deficits defined by multiple individual domains, or you use the T-MOCA, which is also freely available and downloadable via internet, and you use a cutoff of 19, and then you can classify patients into cognitively impaired. Again, here validated against detailed cognitive testing by extensive neuropsychological batteries. And using this cutoff, you have a high sensitivity, specificity, positive and negative predictive value for multi, and in this case also any MCI. So now we've dealt with the practical aspects. Now I would like to move towards mechanisms again, like yesterday, and we've seen this picture already in my talk last evening. Just to remind you that there are multiple vascular causes for VCI, atrial fibrillation, large artery atherosclerosis, and small vessel disease as the most important vascular causes. And on the left is cerebral small vessel disease, which clearly is the most important factor. But you also have on the left cerebral amyloid angiopathy, which is associated with intracranial hemorrhage, lobar hemorrhage, and which is another important cause of vascular cognitive impairment. And on the right, again, I'm going over this because it's so important, you have the vascular, the parenchymal lesions. So mechanisms include multiple territorial infarctions, a lobar hemorrhage, a deep hemorrhage on the right. A strategic small infarct, for example, in the thalamus, might suffice to cause cognitive impairment. Or in the anterior thalamic radiation, as you will see in a minute, it's a strategic location. White matter hyperintensities, if extensive, and if located in strategic locations, are also sufficient to cause vascular cognitive impairment. And of course, as we were talking yesterday, in elderly individuals aged 85, the regular situation is that you have a mix of all these different types of lesions. And then in addition, you may also have Alzheimer pathology and probably a little bit of Lewy body disease and probably a little bit of Parkinson's pathology. And of course, all that comes together and contributes to cognitive decline in elderly subjects. This again, you've seen already. I'm sort of, for educative reasons, bringing this up again. Silent brain infarct. So brain infarcts not associated with a clinically apparent stroke are an important determinant of cognitive impairment. They're very frequent, 5 times more frequent than clinically manifest strokes, extremely frequent in the elderly population. Up to 30% of elderly subjects in population-based studies have silent infarcts on MRI, and they are associated with an increased risk of developing dementia, and the same is true for white matter hyperintensities. So if you have a 40-year-old individual with white matter hyperintensities, you have to stick to this guy. The first thing, of course, you have to do is control blood pressure, measure it regularly, and don't let the patient go until you have understood what's going on. It might be a genetic disorder, it might be CADASIL, or another rare hereditary form if it's extensive white matter, but in the most instances, it will be elevated blood pressure, and it's important to prevent progression of white matter hyperintensities because it predicts cognitive decline and dementia. Again, there's a broad range of vascular lesions on MRI. All of them have been associated with VCI, with cognitive impairment, acute infarcts, white matter hyperintensities, lacunes, so these cystic cavities, dilated perivascular spaces, and cerebral microbleeds. And also these microinfarcts, which we're just starting to understand. They're extremely common in elderly brains, hundreds and thousands of these lesions, and they are also associated with cognitive decline. This is a slide you haven't seen so far. So this is from a study we did in 215 CADASIL patients. Again, the reason we focus on these patients is because they are young, because they have genetically confirmed small vessel disease, and because we know they will not suffer from comorbid Alzheimer pathology. So whatever we find in these individuals, it will be related to small vessel disease. And the question we asked here was, is there any strategic location in the brain that is particularly important for vascular cognitive impairment? So what we did is we did voxel-based analysis. We took the MRI images of all those individuals, and then we did voxel-based analysis and tested each individual voxel against cognitive decline and impairment. And what we found is that, and this has now been recapitulated and repeated by multiple others and confirmed, is that the anterior thalamic radiation and the forceps minor, which you also see here, are strategic locations for both lacunes and for white matter hyperintensities. So it doesn't even matter whether you have a lacune or white matter hyperintensity, it's a strategic location. And the same was true when we tested individuals, sporadic individuals from the Austrian stroke prevention study. These were 581 individuals. And what you see again is that the forceps minor and the anterior thalamic radiation show up as being strategically particularly important for cognitive impairment. It's shown here on this slide again in magnification. And again, to recapitulate, we've also shown that there is a focal degeneration of connecting fiber tracts and of the connective cortex, so secondary neurodegeneration, and this is also relevant for cognitive decline. I won't go into the details. This is other work we previously published. I would like to remind you again, for clinical utility reasons, that there is an imaging marker that we have developed last year and published last year, and that is freely accessible via the internet, that is particularly useful in clinical use because it correlates extremely well with cognitive decline and cognitive impairment. And this is an DTI, so diffusion tensor imaging-based marker based on histograms developed from DTI images, and that focuses on the main fiber tracts. And what you see here on the right is, and I've shown similar data yesterday for small vessel disease, so for CADASIL and for other small vessel patients. Here for the RUN-DMC sample for a large number of 436 individuals, that there's a very good correlation with cognitive impairment in this cohort, and it outperforms all other markers, including brain parenchyma fraction, white matter lesion volume, lacune lesion volume, microbleeds, and so on. So if you are searching for an imaging tool, a marker that allows you to follow patients over a longer time period, and that is automized, fully automized, and can be installed on your MRI scanner, then I'd advise to use this one. Now I would like to, for the last part of my talk, move to prevention and to treatment. So, because obviously in the end we have to do something about it and prevent and treat these patients. So these are, as I see it, the main pillars of VCI treatment and prevention. It's treatment of the underlying vascular condition and vascular risk factors. As I've already mentioned, that blood pressure control is probably the most effective means of preventing vascular cognitive impairment. It's actually the most effective means, probably, aside from atrial fibrillation, treatment of atrial fibrillation, of preventing dementia overall. As you know, hypertension is also a risk factor for Alzheimer's disease. So start early and be absolutely, demanding and consequent in treating blood pressure, and you will prevent a lot of dementia events. Prevent recurrent vascular events, so basically stroke prevention. Any or each stroke contributes, and each silent infarct contributes to risk of dementia, as you've seen. Then treat the accompanying psychiatric symptoms, such as, for example, depression. It's another important aspect, or apathy. It's increasingly recognized as being a very important aspect of vascular cognitive impairment. And then there's specific pharmacotherapy. I'll get back to this in a minute, and of course neurorehabilitation. This is a very impressive study I came across a few weeks ago, published in European Heart Journal, and in my opinion is the first study, and I'm now going to show this in every single presentation on vascular dementia, because I think we need to communicate that also to our colleagues working in the field of neurodegeneration. Again, vascular dementia is the second most important cause of dementia following Alzheimer's disease. And this is at the moment the most effective way of preventing dementia. It's preventing vascular disease. Many of the people working in the field of Alzheimer's disease don't realize that we already have the tools to prevent dementia. Again, this is from a series of 444 6,000 individuals from Sweden. It's a retrospective study. It's a registry study from the Garfield Registry, and includes data on a total of 1.5 million years of follow-up. And what they did is they basically looked at the efficacy of oral anticoagulation in preventing incident dementia in this huge cohort of patients. And what they found is that the hazard ratio of dementia is substantially reduced in patients with atrial fibrillation if you treat them consequently with oral anticoagulants. In the intent to treat population, it was 0.7. In the on-treatment population, it was 50%. So a risk reduction. Imagine this. You can reduce the risk of incident dementia by 50% if you efficiently anticoagulate patients with atrial fibrillation. This is incident dementia. It's not just cognitive impairment. It's incident dementia. On the top, on the right, you see those who were never received oral anticoagulation, and on the bottom you see the curve for those who were in the range of 40 to 80% on oral anticoagulants during the study phase. I think overall 8 years. So this is something we need to tell our colleagues, that we can prevent dementia if we prevent vascular disease. And actually, these are the results. It's subgroup analysis. They are consistent across age groups, gender, whether the patient has an ischemic stroke or hemorrhagic stroke, whether the patient had renal failure, alcohol, frequent falls or not. There's some indication here that the new oral anticoagulants are more efficient in preventing dementia, but in follow-up investigations and very detailed statistical analysis, there are methodological reasons for this result. This was not a rock-solid finding. But anyhow, it's really oral anticoagulation that prevents dementia. And so for the last few minutes, I would like to move to prevention using multi-domain interventions. This is probably what we do anyway in regular, in daily clinical practice. So this was the FINGER trial, a trial in elderly subjects who were enriched for risk of developing cognitive decline, conducted mostly in Finland and Sweden. So they were individuals with a high, what they call CADE score, high risk for developing cognitive decline. And these patients were treated with a multi-domain intervention that included nutritional guidance, physical activity, monitoring and management of vascular risk factors, and cognitive and social activities. Very expensive intervention, quite demanding. So here's what happened. So individuals were randomized either to see a doctor, and the doctor at the outset then told them how important it is to keep on control on weight, do regular physical exercise, control vascular risk factors, engage into social and cognitive activities, and to live a healthy life. Then this patient was sent back to the family practitioner and followed for 24 months. And the other patient in the intervention group received regular nutritional counseling, regular physical exercise, including aspects of muscle strength and aerobic training, cognitive training in multiple sessions, and then was controlled for the management of metabolic and vascular risk factors. So this slide here shows all those activities. So, here, for example, was regular patients were weighed regularly. They did muscle training. Here went to do physical exercise and were engaged into social activities. And actually, individuals very much enjoyed their activities. Here is one quote from one participant. I have friends who are jealous when they hear all that I have been offered to do at this course. Anyway, they really seem to enjoy the activities. This also included regular computer games, for example, online, or again, engaging into social activities, playing cards, and so on. And these are the results. So, as you see, after 24 months of this very extensive intervention, there was a significant improvement on the total cognitive score, but particularly on executive function tasks, less so on memory, but on executive function tasks and on processing speed, which is what you would expect if you were dealing with vascular patients. So again, reflecting that what we do here is we do vascular prevention. This is what we do. So this is, I think, very good news, and there was only one side effect of the whole intervention, and this was musculoskeletal pain because patients did physical activity. So really, this is a very healthy intervention, but it's, again, very demanding. Of course, this is reality. Patients use the elevators instead of using the staircase, even if they go to the fitness center. So the problem with vascular prevention, it's very hard to achieve. People don't quit smoking. People don't do physical exercise unless they really have to. And this is what managers do, right? Managers who can afford it, who have a lot of money, they get a personal trainer who wakes them up in the morning and says, you have to go out, I take you out, and then they entertain the manager. But of course, this can't be done in the general population. Last point is vascular prevention, is pharmacological treatment of vascular dementia. So there's a couple of agents we have at hand, at least in Europe and in North America. This is what is currently used. So these are the cholinesterase inhibitors, donepezil, rivastigmine, galantamine mostly, and then the use-dependent NMDA receptor antagonist, memantine. These agents are still disputed in terms of their efficacy of efficiently treating vascular cognitive impairment. You know they have been approved for Alzheimer's dementia, but they have not been approved for vascular cognitive impairment, at least not in Europe and the US. The donepezil has been approved, I think, in New Zealand and in Far Asia. Memantine has been approved in South America. But the reason the FDA didn't approve these drugs for treatment of vascular dementia is because they require efficacy regarding cognitive scales plus efficacy regarding clinical global assessments. And this is where the problem is. So this is from a review in 2017 for donepezil on the top, 5 milligram, 10 milligrams, galantamine, 24 milligrams, rivastigmine, and memantine. And what you see is that all these agents perform reasonably well in improving cognitive endpoints in the ADAS-Cog. It's a global cognitive score, but again, it doesn't include processing speed items to the extent that, for example, the ADAS-Cog does. So it doesn't really capture as well the deficits in vascular patients. But the problem is on the right, and this is that these patients did not really benefit in terms of global clinical assessment as assessed with the CIBIC Plus or the CGIC. Except for donepezil on the top, which there was a trend at least for some improvement. So, and this is my last data slides here. This motivated us back in 2007 to engage into a proof of concept trial in CADASIL patients. The reason we did this, and the reason ASI, the company, engaged into this with us, and we actually met, both of us wanted to do this trial, was that the FDA always said, the treatment effects you're seeing here in the vascular patients, they are not the vascular treatment effects. What you're treating is you're treating symptoms in comorbid Alzheimer's disease. We're always getting back to the problem that in elderly individuals, and the same as in Alzheimer trials, of course, you have patients who have both Alzheimer pathology and vascular pathology. So it's very difficult to disentangle the effects. Are you treating Alzheimer pathology? Are you treating vascular pathology? Of course, you could say, I don't care. I want to treat the patient. I don't care what I treat. I want to help the patient. But for regulatory authorities, it's important to have an indication and a label. So we did this trial in CADASIL patients because we reasoned that they are young, they have a defined etiology, they have no comorbid Alzheimer pathology because they are young. So it's a proof of concept trial done here in Notch3 mutation carriers with a cognitive problem, a mini-mental state examination score between 10 and 27, and we treated them with 5 milligram donepezil, and after 6 weeks we switched to the higher dose. And this is the randomization scheme. Overall, we included 168 individuals, and these are the results for the primary global outcome measure, which was the ADAS-Cog. It includes a little bit of executive function scores, but it was negative, as you see. But what was positive was the result on the trail-making test that I've shown previously on my video. So these patients do benefit from cholinergic treatment with donepezil in terms of their executive function, which is actually the leading problem in these patients. Just to conclude, there's a problem for some patients to even complete the test, because what you do, as you've seen, is you stop the time the patient takes to complete the test. So this is the different way of looking at the results, and what you see is that patients here in red who received donepezil, they improved in terms of the time requested to conduct the task under donepezil, but they didn't improve in the placebo group. And this was statistically significant. So, in summary, VCI is a huge problem. It's a growing problem in aging societies. Clinical characteristics include processing speed and executive function items. It's important to test these patients, and it's informative to test these patients. If you test patients with stroke for cognitive abilities by, for example, baseline MOCA, a brief assessment tool that includes processing speed items. It's predictive of cognitive decline, future dementia, clinical outcome in general, and including mortality. You've seen that there are strategic lesions for cognitive impairment, bivascular lesions. It's the anterior thalamic radiation and the forceps minor. And you've seen that we can efficiently prevent cognitive impairment by treating especially atrial fibrillation and blood pressure. And at present, vascular prevention is the most efficient means of reducing the incidence of dementia in aging societies. I'm at the end of my talk. I would like to thank you for your attention and again invite everybody to join the European Stroke Organization conference this year. Thank you very much.
Questions?
Thank you, Professor Martin, for such a, elaborated discussion on the vascular dementia. My question is for the component of prevention and treatment. I found a lot of detail about the exercises, diet, and other things in the lifestyle. What is the role of sleep and sleep disorder in your model of lifestyle modification in prevention of vascular dementia? Sleep and sleep disorder.
Pardon me, I didn't.
For prevention of dementia, vascular risk factor.
Sleep
Good
and
sleep and sleep disorder.
Quality of sleep.
To my knowledge, there's very little data on this. I mean, obviously, sleep apnea syndrome, right? So associated with obesity is a major risk factor for, as you know, for stroke and also for developing silent brain infarcts. So treating sleep apnea syndrome is, for me, would have high priority if you speak about so treating sleep disorders and dementia prevention. Other than that, I wouldn't know I'm not aware of any larger studies that would have systematically explored, and specifically there are no interventional studies that would have explored any attempts to improve sleep quality and their impact on dementia risk.
And the second question is related with the pharmacotherapy. Is there any study related with ginkgo biloba in vascular dementia compared to the current LFT?
There are, but there are no randomized controlled trials of sufficient quality on ginkgo biloba that would have shown a convincing treatment effect on vascular dementia incidence.
Thank you.
Hello. I have one question. You told role of oral anticoagulant in patients with atrial fibrillation who will benefit with vascular dementia. So, if you started the oral anticoagulation and patient in meanwhile develops a lobar or subcortical bleed, so how will you proceed? Will you continue the same vitamin A or newer anticoagulant?
So let me please, because I have some difficulties here from the front to fully understand the questions. Did I get your question right? That what you're asking is, what are you doing with a patient with a lobar hemorrhage, right?
Yes.
So, okay, so you're making an important point. This is a difficult question. And this is heavily discussed at the moment, not only in the context of vascular cognitive impairment and dementia prevention, but stroke in general. What do we do with a patient who has a lobar hemorrhage, who has atrial fibrillation, and because of that has a clear-cut indication to be anticoagulated, but the physician is afraid of an increased risk of hemorrhage, which of course is true.
Yes.
And this is balancing the benefits and risks of oral anticoagulation in these individuals. First of all, of course, you can reduce the risk of an OAC-associated hemorrhage, ICH, if you treat any other modifiable risk factors like hypertension. You might also find out that the hemorrhage occurred under oral anticoagulation because the patient was over-anticoagulated. So then, of course, you can try to control these factors. You can switch to new oral anticoagulants, which I would always do, because they are associated, as you know, with a much lower risk. My prediction actually would be that with the new oral anticoagulants, in many cases, you can, without substantially increased risk and to the benefit of the patient, treat the patient even with a low hemorrhage. And then, of course, there's always the opportunity, and this is currently investigated in randomized controlled trials. For example, place an atrial septal occluder, an atrial, appendix occluder. So there are other means of treating these patients.
Okay. If same patient has a coronary risk factor, if such same patient, cognitive impairment, we have started with oral anticoagulant, and patient has a coronary risk. So will you start him oral anticoagulant with aspirin or ticagrelor?
Can you repeat this question for me? I had difficulties understanding.
I'll repeat. Patients with cognitive impairment, who has white matter changes, who is fitting for the mild cognitive impairment, and patients with atrial fibrillation. You have started with the warfarin, vitamin A antagonist.
So if I understood you correctly, then your question is how to deal with white matter hyperintensities and other imaging findings, or in the presence of already mild cognitive impairment. Would you still...
If patient has added on coronary risk factor.
What risk factor?
Coronary.
Coronary. Now, okay, coronary risk factor. Well,
so will you continue oral anticoagulation plus aspirin, or you will continue only oral anticoagulant?
Well, patients who have atrial fibrillation and coronary artery disease, I would always request to anticoagulate these patients. This would clearly have preference to me. I would not take into account the presence of white matter hyperintensities. I would not take into account the presence or absence of vascular cognitive impairment. This is a different question. I think it's important to keep in mind to differentiate with what you want to achieve. Yes. The problem with a patient who has mild cognitive impairment, that he is already impaired, or let's say a 90-year-old fragile elderly gentleman who is severely demented, there are no relatives, he is in a nursing home, but has atrial fibrillation. You have to ask yourself what you want to achieve in that person, the treatment aim you need to define. This is a different question from how you achieve it most efficiently. If you want to prevent stroke, if you want to prevent dementia, you have to anticoagulate a patient with atrial fibrillation. It's the most effective means of doing it, and you should not search for arguments not to do it. Presence of white matter disease is no argument. Presence of microbleeds is not a valid argument. If the patient has multiple lobar microbleeds plus 2 previous lobar hemorrhages, I would be a little bit careful. Now, but you're addressing a very important question. What do you do with a patient who, in addition, has coronary artery disease?
Yes.
I would still give the oral anticoagulant. Okay. What do you do with a patient who has an acute coronary syndrome? That patient would need platelet inhibition, especially in the first phase, probably needs stent. If there's a stenting procedure, this is posing more challenges. Then he needs dual antiplatelet inhibition, at least in the first.
That was a worry.
Yeah, but there are data from registry data and also from trials, especially, and I think the best data are currently on dabigatran, showing that actually even in the presence of an acute coronary syndrome and dual antiplatelet inhibition, especially in the presence of the new oral anticoagulants, these patients do fairly well. I would try to keep the period as short as possible, but follow general guidelines and always consult your cardiologist for the duration of dual antiplatelet inhibition.
Thank you.
Sir, Dr. Martin, in the large cohort study which showed this, which of the oral anticoagulants which they used, the one which you showed the prevention of, or the NOACs or the traditional anticoagulants? The registry study which you showed.
Yeah, the most of them.
Is it a mixed one or?
It's a mix. Most of them were actually warfarin. The majority was on warfarin. And what I always say is, you know, the important thing for us to remember is we need to efficiently perform oral anticoagulation. That's the most important thing. Whether you do it with warfarin.
I understand that. I want to know which is the best one.
That's a difficult question. Was
there a one-to-one comparison done about NOACs versus warfarin in that study?
I would always go for the NOACs if possible, but the most important.
In that study, was it done?
It was done. The NOACs were part of it. It was, from what I recall, it was all sorts of NOACs. So it was not one particular NOAC. It was a mixture of NOACs. but it was the minority of individuals who received NOACs. And NOACs were not superior in terms of preventing dementia, not clearly.
Majority were on warfarin.
Pardon me?
Majority were on warfarin.
The majority were on warfarin.
My second question. We have seen a subset of patients, young patients, who had MCA infarcts with no white matter involvement they had only MCA infarcts, young strokes. Follow-up showed, the follow-up studies showing that they were progressively having cognitive decline. All young individuals who had an MCA stroke, following that they are having cognitive decline with no white matter. Did you have any such groups which you have seen?
We have not systematically followed on this type of individuals. I'm a little bit too surprised to hear that individuals, young individuals, who obviously have a much better capacity of compensating for a brain tissue loss with not even a very large MCA infarction, as I understand. You said a minor stroke and a smaller infarct would progressively deteriorate. This is a little bit counterintuitive to me, but it might be, and if this is the case, you should definitely publish this series and thoroughly investigate your patients and come up with detailed neuroimaging also and follow-up, ideally with CSF, ideally with amyloid PET. I would like to understand what's going on here.
Thank you.
Do you think in such cases, programmed neural cell death has got some role?
Pardon me?
In such cases, programmed neural cell death. Many times we see that
might be.
Even after the stroke, they keep on worsening.
It might be it might be, but again, I mean, what we've shown is that if you have a stroke, you get secondary neurodegeneration. But whether this actually accounts for cognitive decline, we don't know. We've not investigated this. It requires very detailed neuroimaging.
Thank you, Dr. Martin. Quite comprehensive lecture. Thank you.
Coming to the last talk of the session, I'll invite Professor Mark Brashinsky for his talk.
This is on? Yeah, that's great. Once again, we will now dive into the world of migraine, and this time with the concentration on episodic migraine. My disclosures didn't change much from yesterday. So why we're talking about migraine so much? Because it is the most prevalent neurological disorder, actually. This is by far #1 prevalent neurological condition. And migraine is a brain disorder. There is no arguing about it, especially considering all the mechanisms, all the brain pathology that we are now aware of. And another reason is that it's not only the most prevalent, but it's also the most costly neurological disorder. For instance, just recently published socio-economic report in the European Union clearly highlighted that migraine costs to the society, to the migraine general costs more than epilepsy, multiple sclerosis, and Parkinson's disease combined. So it's a huge socio-economic impact of the disorder that migraine represents. So it's not only the most prevalent, but it is the most costly neurological disease, affecting especially young people. So because the prevalence of migraine is the highest in young people. We also know that impact of migraine has multi-dimensional level. I mean, its impact on individual level, how people are suffering from it, but it also has an impact on employers because, for instance, due to migraine, every year employers lose 270 working days per 1,000 workers, and it should make employers actually worried and contribute more into migraine. And to society, there are some data, and we can compare USA and Europe data. For instance, total annual costs in Europe is 27 billion euros for migraine. Imagine if we can, in part, save some of the money and let's say use it for scientific research or reimbursement of medications. So this is quite considering. So getting to clinical stuff, yesterday also already mentioned that International Classification of Headache Disorders is a way of systemizing our knowledge, our clinical knowledge about primary headache disorders and also some secondary headache disorders. According to classification, we can differentiate between different forms of migraine. And in terms of episodic migraines, there are as you are all aware, there are some subforms like migraine with aura, migraine without aura. Migraine with aura has all forms of it. So sometimes we even say that there are migraines, so many forms of it. If you compare migraine phenotype to different other primary headache disorders, the heterogeneity here is much larger than, for instance, intention type headache or cluster headache. Especially interesting are syndromes that previously were associated with childhood episodic syndromes. Now we know that they are not limited to the childhood. They can be rarely seen in adult people as well. And we are talking about those syndromes that might not even have a headache as a primary complaint there. For instance, we are talking about cyclical vomiting syndrome or abdominal migraine with pain in the stomach, or it's benign paroxysmal vertigo. And I'm not talking about classical vestibular disorder, which is a problem in older age usually, but in young people, in those in whom it keeps repeating on regular basis, etc., etc. So we are talking about quite heterogeneous phenotype here. So the most classical migraine form is migraine without aura, as you all are aware of diagnostic criteria, that it has to have at least 2 criteria from C-section, which means unilateral location, pulsating in quality, moderate to severe intensity, and aggravation or causing avoidance of routine physical activity. As you can see, you don't have to have all of these criteria. At least 2 has to be present. So it is quite common for migraine to be bilateral and pressure-like. If you have all other criteria fulfilled, we see a lot of these patients, but somehow doctors sometimes misdiagnose it. They totally forget that migraine does not necessarily has to be pulsating unilateral. So the more accompanying symptoms we have, the more clear we are about the diagnosis, and we're talking about nausea, vomiting, photophobia, phonophobia, which is not present in the current diagnostic criteria, but is quite often in patients with migraine is osmophobia. Avoidance of smells. They don't tolerate smells during the attack. For instance, I don't know, a young lady, she just adores her Chanel No. 5 or whatever the adore she uses, but during migraine attack she says, no, I can't tolerate it, it makes me more sick, it aggravates my headache. So osmophobia is also quite prevalent in migraine patients. And I also believe that in future classification, probably osmophobia will be present as a diagnostic criteria, probably as well. So migraine with aura is slightly different in terms of presence of aura. And aura is a clearly defined condition in which symptoms of aura evolve during minutes. And this is important to ask patients how their symptoms start, because differential diagnosis might include transitory ischemic attacks in some cases in the emergency room, and if patient says that his or her symptoms started like this, you probably think TIA, but evolving of symptoms like spreading of tingling sensation, let's say, or hypesthesia or visual disturbances during time. This is clearly suggestive of not ischemic event, but to a migrainous genesis. And at least one there may be several auras within one patient, but at least one has to be unilateral. And this is related to known pathogenetic mechanism of migrainous aura, which is called spreading cortical depression. And these are some videos showing how it can be visualized during using different techniques. For instance, if you are talking about methods to measure actually blood flow during aura, we know that it is reduced during cortical spreading depression, which is related to brain's autoregulatory mechanisms of vascularization itself. And yeah, classical migraine aura actually should last up to 1 hour, but we know in some patients it can be prolonged aura. And if you have some atypical features, then you might think about the possibility or a need to visualize patient to exclude secondary causes, because classical migrainous aura is more or less under 60 minutes. What also should be kept in mind is that headache phase in some patients with migraine with aura might not always be migrainous. I mean, some patient might have migraine with aura with headache that is similar to tension type headache, or there are some patients who have only auras without headache. These are also the possibilities we should be aware of. So what are here are some examples. Actually, you can find these on a very known scientific website called YouTube, but you should be aware that there are a lot of stuff there which is not quite accurate. If we talk about visual aura, then classical visual aura is black and white. And this is a good example, good video, if you see, where you see spreading of aura. This is called scintillating scotoma, clearly lateral in one half of the field, visual field. Of course, this video is quite fast. In real life, it takes more time. But if you have, for instance, colorful auras, patients complaining of colorful auras, in this case you might be worried because colorful auras are not typical for migraine. You might look for other causes, and some patients might have, let's say, occipital epilepsy, and these should be excluded. So here is one video. We hope that we will have a sound.
CBS 2's Serene Branson is live at the Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy debatation tonight. We had a very Darrison, but let's go to Terrace Chase and look for the bet. They have the pet.
And the Grammy.
She didn't receive a Grammy for that, obviously. It was an event that happened live on air, and as you realize, this young, beautiful journalist had a sort of speech problem during this, which can be defined as dysphagia, actually. Of course, everybody was concerned about her having a stroke or something, but later on, when she was interviewed, she said that she has migraine with aura, and her auras can be speech-related, so dysphasic auras. So these are just some examples, and once again...
CBS 2's Serene Branson is live at the Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy debatation tonight. We had a very Darrison by, let's go to Terrace English for the bet, they have the pet.
Yeah, just to illustrate for you that what type of speech disturbance can be related during with migraine aura. So, but there are also another forms of migraine with aura, some specific forms, in which case we can talk about migraine with brainstem aura, which was previously called basilar type or basilar migraine. Current classification recommends not to use basilar term for this situation because, well, the term basilar migraine derives from the time of Wolff's theory, where when migraine was considered to be a vascular disorder, and that's why they said that basilar artery, basilar migraine, etc. But now we know that it is neurovascular disorder. The primary pathogenetic mechanisms are related to dysfunction in the nervous system. We are talking about trigeminal complex. And the vascular changes, what we see during migraine, are secondary to that. And that's why it is recommended now to use the term migraine with brainstem aura. And by definition, this is a form of migraine with aura, in which case aura can consist of symptoms related to brainstem dysfunction like dysarthria, vertigo, tinnitus, double vision, or even decreased level of consciousness. So at least two of the brainstem symptoms should be present in order to diagnose it. Another subform of migraine with aura is hemiplegic migraine. Nowadays we already know that hemiplegic migraine can be familial. We already know 3 genetic loci related to these situations, and can be sporadic as well. But the clinical presentation is different from classical migraine with aura due to, first of all, motor deficit that evolves during the aura. Patients can also have other cortical dysfunction symptoms, aura-like, and the time frame for these symptoms can be a bit longer than in classical migraine with aura. Why we have to separate these two forms is that in both, in hemiplegic migraine and in migraine with brainstem aura, it is recommended, if possible, to avoid treating attacks with triptans, which have vasoconstrictive effects, and we don't want to take risk of having vascular ischemic side effects of triptans with hemiplegia, hemiparesis, or brainstem stroke, for instance. That's why in these two migraine with aura forms, it is recommended to avoid triptans for acute treatment. Then there is a retinal migraine, as you know. In this case, aura has a phenomenology of visual field defects, but not on occipital type, cortical type, with visual disturbances in one side of the visual field, but it is related to one eye. So, but these can be negative visual phenomena, we need to ask patients to draw the phenomena that they have, if possible, or describe it in detail to be able to diagnose this one. So these are clinical subforms, and we know that migraine has a certain pathogenetic mechanism in which I will not go into details, just to remind you that all migraine attacks have different phases. It also may start with premonitory symptoms, which can last up to a couple of days prior to attack. Then in case of aura, you have aura. If we don't have migraine with aura, then a headache phase, in which case we have hyperperfusion in the brain, and then there is a resolution of migraine attacks, and many patients describe after the resolution post-monitory phase with some non-specific complaints presenting once again, can last for a couple of days after the attack. So what we actually know from clinical perspective is that many patients with episodic migraine describe very different trigger factors that can provoke attacks, and they were investigated on the trigger basis, but actually nowadays we think of migraine as a threshold disease, sort of considering the pathology, what we know, what's going on in the brain. So there is not so much important what is the trigger factor itself. The important thing is how brain reacts to certain factors that derive either from the outside of our body or from the inside. And these trigger factors are non-specific. What we know now, thanks to also some neurophysiological studies and other investigations, that the pathology can be related to so-called habituation deficit, in which case our brain is, not our brain, but brain of people with migraine is not able to sort of process normally all the information that it has to process. And information can be derived, as I said, from the outside world. It can be climate changes, it can be, I don't know, something we eat or drink. It can also be something from the inside of our body, like many patients with migraine say that they have muscle tension in their neck before the attack. So once again, this muscle tension can be non-specific, but how our brain reacts to that, that is the problem. And this is habituation deficit actually quite elegantly explains what we know about different variable trigger factors. And it also related to central sensitization. And we know that cortical activation, cortical disturbances can be as a trigger factor for migraine with aura, with cortical spreading depression. Cortical spreading depression can activate deep centers, the trigeminal system, with the all following cascade of changes that we know for years were going on in the brain of people with migraine. So these are all non-specific triggers that we can ask patients to avoid, but only in case patients have these trigger factors in their lives. Because many times I hear patients talking, I've read on internet that if you have migraine you shouldn't eat cheese, so I stopped eating cheese. So you should ask them, have you ever had an attack after eating cheese? They say no, so don't avoid that. The problem is not in the cheese, the problem is how our brain reacts to some certain things in case of migraine. So if patient doesn't have these trigger factors specifically provoking attacks, she or he do not have to avoid them. So on more practical recommendations, the management of migraine is of course a complex one, and there are certain differences in terms of managing patients if you have low frequency episodic migraine or high frequency episodic migraine. In case of low frequency episodic migraine, you should stick to basic recommendations. In terms of high frequency episodic migraine, all the preventive medications should be considered, and this topic I covered yesterday. In order to differentiate, we always ask patients to keep headache diary, to register headache days, and register number of medications, painkillers that they take in order to avoid medication overuse. If patient has filled the headache diary at least for 3 months, then you have a sort of objective information about the frequency, and you can start planning treatment. Of course, when we first have our patients, we rely on what patients tell us, so what information they give us. And when we have high-frequency episodic migraine, of course, we put a lot of attention to educating patients. In our headache clinic, these patients are all admitted to headache nurse, who talks to patients about the necessity of sleeping regularly, eating regularly, doing physical exercise, etc. So this is actually, I know very little about in practical terms because I have a headache nurse. She's very comfortable. She works with patients on these terms. And she also helps a doctor to select those patients who are in need of physiotherapeutic approach by physiotherapist and or neuropsychologist, interventive neuropsychologist doing cognitive behavioral therapy. But also, there is one example that I want to give you. For instance, what also our nurse does, she goes into dietary details with patients, what they eat, what they drink, and one important topic to discuss with patients with high-frequency episodic migraine is caffeine consumption, because it is known by now that high caffeine consumption actually can lead to increased frequency of migraine attacks and leading to chronification. It's a risk factor for chronification because caffeine has analgesic properties, and like we don't recommend patients to take very often painkillers, the same applies with caffeine. And there are also some studies showing that a simple recommendation of reduce coffee or other caffeine products can reduce the number of headache days in these patients. And it's as simple as that. And that is what a nurse can actually achieve working with these patients. Speaking Dr. House style, we can sort of explain in order for you to remember. Dr. House said, if I have no coffee, I have no brain, right? If you have no brain, you don't have migraine, right? That's easy. And actually, now I remember that one German professor, Professor Christoph Dünner, in order to emphasize that migraine is a brain disorder, he always tells the same joke. He says, you see, migraine is a brain disorder. That's why orthopedic surgeons don't have migraine. I don't know why he loves them that much, but okay, that was a joke. But yeah, mathematically speaking, if you don't have coffee, you don't have brain, you don't have brain, you don't have migraine, so if no coffee, there is no migraine. That's the easy way to memorize it. Okay, in some countries there are algorithms for managing patients with migraine, and it all starts with the attack treatment, starting with first-line medications, which are simple analgesics, and only if those are failed, which happens in 80% of patients with migraine. Only 20% of patients are happy with non-steroidals during the attack treatment nowadays. Then you go to oral triptans. If first triptan doesn't work, it is not necessarily the group effect. That's why we recommend patients to try different triptans before they find something that actually works for them. And if all they are tried correctly, in this case we consider prophylactic even in some cases with maybe low frequency but severe attacks. So how do we treat acutely migraine? The first rule is to start as soon as possible. First line recommendation is non-steroidals, but preferably using dissolvable in order to achieve as quick effect as possible. But like I said, it works only in 20% of cases. All the rest nowadays need triptans, which are 1B, 1D receptor agonists, thought to be more or less specifically represented in cranial arteries, but we also know that these receptors are also represented in coronary artery, in systemic arteries, in which cases there are some contraindications for triptans, as you know. For this, we hope that lasmiditan, which is a serotonin 1F receptor agonist, is hoped to be more specific, because they say that 1F receptors are even more specific to cranial arteries. What we should always tell our patients is what to avoid, what not to do when treating headache, migraine attacks. First of all, avoid combination therapies. Especially it is important to tell patients with high frequency episodic migraine, because combination medications are in considerably higher risk of developing medication overuse headache. Although I know that in some countries, for instance in North America, there are some combination preparations like sumatriptan with naproxen, and there are studies for some other triptans plus NSAIDs combinations, but these are all for rare use, not for frequent use. And of course, there is no place for opioids in migraine, because migraine is, as I said, trigeminal vascular disorder. Trigeminal. There are no opioid receptors in trigeminal system, and opioids are high-risk medications, so we don't use opioids. In case of status migrainosus, we use steroids. It was discussed yesterday, and now we are looking very much forward for CGRP antagonists. GPANs, it was mentioned during another presentation yesterday, and now actually this year are coming biological medications. They are mostly for prophylactic treatment, but there are studies ongoing for acute treatment as well. So, non-steroidals, here are some examples. You can use those, actually you can use triptans with antiemetics as well, depending on phenotype of migraine attack. If patients are having early vomiting, in this case, it's probably very much needed to start with antiemetic. Triptans. All randomized controlled trials for all triptans show that all triptans are better than placebo. The differences are basically we can separate from each other by the speed of action. So we have so-called fast-acting with the golden standard sumatriptan, and other triptans like zolmitriptan, rizatriptan, elatriptan, and almotriptan. They are short-acting. And then there are long-lasting triptans like frovatriptan and naratriptan. They have their own sort of patients to when frovatriptan and naratriptan can be preferred. These are those patients who are having long attacks. They take triptan as soon as possible. They have first good effect, but then their attack comes back the same day or next morning. In these patients, it is much more useful to use long-lasting triptans, especially frovatriptan, which has a half-life of 24 to 26 hours. And these long-lasting triptans can also be used for prevention of menstrual migraine, the only migraine in which case triptans can be preventively used, because this is prognostically well-known period when a lady will have an attack. And menstrual migraine, just to remind you, it is the form of migraine in which attacks occur only exclusively during menstruation, no at any other period, plus minus 2 to 3 days. So in this case, 2 days before the attack, they can start taking frovatriptan, do it for 5 to 6 days, and efficacy is roughly 66%. There are some studies and protocols for that as well. As I mentioned, triptans have their contraindications, but fortunately, most of migraineurs are young, healthy people. So generally speaking, triptans are having quite a favorable safety profile. Ditans. Yeah, ditans is a new group. These are serotonin 1F receptor agonists. Actually, there is only one medication now that, has completed the studies. Studies called very nice, like Spartan and Samurai. It's very well memorized, and they showed both the safety, favorable safety profile, and efficacy up to 64% of lasmiditan in headache, migraine headache attack treatment. And now there is an open label extension trial called Gladiator that is ongoing, and we're looking forward to seeing the results. So these are the basic concepts of treating episodic migraine. As I said, high-frequency episodic migraine is a type of migraine that needs preventive treatment that I covered yesterday, which is very important. And if we have low-frequency episodic migraine, in this case, we can stick to non-medical prophylaxis and attack treatment, as I covered today. So if you want to know more about headaches and migraine in particular, this year in September we'll have 12th European Headache Federation Congress in a very beautiful place in Florence. So you're all welcome. Please join us. And that's pretty much all that I wanted to tell. Thank you very much.
Any questions? He's asking about preventive aspects.
Preventive? In preventive treatment. Actually, I was talking yesterday about prevention because it is preventive treatment is must in chronic migraine and is highly recommended in high-frequency episodic migraine. And as we discussed yesterday, the first-line medication like propranolol, amitriptyline, and topiramate, with some number of second-line, third-line oral medications, plus we are using Botox. We recommend transcutaneous electrical stimulation. These would be the major points from the point of view of prevention of high-frequency episodic migraine.
If there are no questions, we close the session. I hand it over to Ketki.
Thank you, sir. Now I invite Ms. Sabine Adam to address the guests.
I would like to thank you all for joining the conference on behalf of EAN and ESO, and would like to announce that the DP Gupta Fellowship Award is going on, and I'm very proud that we have Pravan Kumar Sheoma here from the King's George Medical University in Lucknow, who has done that in the last year. And I would encourage you to also get your fellows to apply at the EAN website for the new fellowship, which is going to be announced within the next 2 months. Thank you very much, and I would like to ask Pravan to come to the stage.
Thank you very much, organizing committee, to inviting me to share my experience during my fellowship last year. So all the first, I would like to pay my tribute to all the distinguished faculties from abroad and India, delegates, members from the EN and organizing committee here. So I would like to say that this is the very good opportunity for the Indian young neurologists, young neurophysicians to conduct a research using infrastructure of European infrastructure because of two reasons. First, whether we are in public sector or private sector, we are facing a lot of patient load in our country. So if at all we have to do a good research, we have to have time, and that time we actually lack that time here. So this is a very good opportunity. We can go, we can use infrastructure, and we have time dedicated to research only, and that is what has happened with me too. So it was a learning experience for me from the process of application to submission of the final submission of the project report and paper. I would like to share briefly, like during application process, it was the deadline was closing. I wanted to work on EEG, and so I submitted a project like with the title Interictal and Ictal EEG changes in EEG changes correlating with lesion or in structural neuroimaging. So I just wanted to do like whether EEG can be helpful in localizing a focus in correlation with the structural neuroimaging. So I submitted this project, and this project was actually considered, but I could not get acceptance letter from any of the European center. So Chair, EN Education Committee, Dr. Hanaka was kind enough to grant me the, provide me the links to contact people in European centers and give me 1 month time to reply. And I contacted several people, and I got reply from Dr. Sander Baneski from DNA Lund, National Epilepsy Center of Denmark. Actually, he not only read my project, he edited also, and the title was then modified according to his after his editing. It was modified to interictal and ictal source imaging from the EEG in pre-surgical evaluation of focal epilepsy, refractory focal epilepsy. Electrical source imaging from EEG data was again new to me. Frankly speaking, I knew about voltage mapping, but I did not know about electrical source imaging from the EEG data. And when I actually then completed the application process, and finally in the month of probably August or September, I got a news of selection of my project for the fellowship, Dr. D.B. Gupta EN Fellowship 2016. And then new problem came, like visa. I had a problem in getting visa, Danish visa. There were because of certain regulations of Danish visa process, this 6 months fellowship was split in 2 visits of 3 months fellowships, at least 6 months apart. And for that, I needed documents from EN. Again, EN was very kind enough to grant me documents for the application process of the visa. I got visa, and I then traveled to Denmark to finish first half in the in year 2016, starting from November 19. And I could say the center, Danish Epilepsy Center, that is excellent, a very good electrophysiology lab with high density source imaging facilities. I could see Dr. Sander used to personally actually call me whenever he used to read EEGs, and he always involved me in source imaging whenever he did source imaging. So first half actually I spent in reading EEGs and collecting data, and second visit somehow favored me in collection of outcome data also post-surgical outcome data. So this way my whole study, whole project actually the results got better. And before coming back to India, I could submit the paper in time, and apart from this, I also worked and did a meta-analysis and contributed to one book chapter also. So this 6 months period was actually fully used in academic work only, research only. And I am happy that I could finish the work or the project in time, and I could submit the paper. And I would say for future fellows that it's a very good opportunity. Here in India, we do research to get promotion, and most of the time. And but this 6 months period only for doing research work is very good to do a very good quality research work, which can give the results, real results. And I would wish future fellows to, I would wish all the future fellows best of luck. And thank you Ian, thank you Lupin, thank you organizing committee.
Thank you all speakers and delegates for being here for these 2 days. It was really an enriching experience and a great time with you all. It's time to felicitate for the wonderful efforts that have been put in these last 2 days. I'm sure we all will go back home with a lot of positive messages, lot of learning messages from this 2-day symposium. With this, I invite our Senior General Manager, Sales and Marketing, Ms. Sumita Mohapatra Pani ma'am, to please come on the dais and felicitate all our speakers and the program coordinators. I request Sumita ma'am to felicitate Dr. Ramesh Patankar, our program director, for sculpting this program and really bringing it to a meaningful shape. Thank you, sir. I request Patankar sir to please stay back on the dais. Now I invite Dr. Professor Lakshmi Narasimhan sir to please come on the dais, and Dr. Ramesh Patankar sir to felicitate him. Thank you, sir. Now I invite Dr. Praveen Gupta to come on the dais, please, and get felicitated from the dignitaries. Thank you, sir. Now I invite Professor Ian Novi for his wonderful talks on epilepsy. Now I invite Dr. Professor Mark Braschinsky for his amazing talks on migraine. I invite Dr. Professor Ake Hitharju to please come on the dais. I invite Dr. Professor Martin Dishgens to please join us on the dais for felicitation. Thank you, sir. Now I invite Ms. Sabine to please come on the dais. I also invite Ms. Martina to please join us for felicitation. Thank you, sir. Whenever there is a program or an event which is to be planned, there's a lot of back work which happens before and after the event. Since this program is in Bombay, our Mumbai team of Lupin Mind Vision has really taken a lot of efforts. I would like to call Mumbai team, which is actually a team of Mr. Raghunath Vadekar and Prasanjit Acharji. Under the leadership, this event has really become successful. I call entire Mumbai team quickly on the dais. Thank you, Mumbai team, for your wonderful efforts on this event. Thanks a lot for making it successful. I invite all of you for a lunch, and with this we end this 2-day symposium. Thank you so much and have a wonderful journey ahead and have a great year ahead. Thanks a lot.